practice นะคะอาทิตย์นี้เป็นอาทิตย์ที่5แล้วนะคะเรามาเกือบถึงครึ่งทางแล้วนะคะทั้งหมดมี12อาทิตย์นี้เป็นอาทิตย์ที่5นะคะแล้วก็เป็นอาทิตย์สุดท้ายของ CT modality นะคะซึ่งเราจะมาพูดถึงในเรื่องของdual energy spectral CT นะคะแล้วก็ในเรื่องของ cardiac CTA นะคะส่วนในเรื่องของ CT fluoroscopy เนี่ยเราจะไปพูดในเซสชันที่เป็นเรื่องของ interventional radiology นะคะซึ่งก็เช่นเคยนะคะเราก็ได้รับเกียรติจาก expert นะคะดร. Sam Brady นะคะจาก Cincinnati Children's Hospital เป็นหัวหน้านักฟิสิกส์นะคะที่ Cincinnati Children's Hospital ที่จะมาเล่าให้เราฟังถึงว่าจะมีในเรื่องของเทคนิคอะไรบ้างในการ optimization นะคะแล้วก็สามารถลดโดสให้คนไข้ได้นะคะ Good evening Sam Welcome to the lectures. Yeah. So this is a week 5 for the total of 12 weeks. So almost halfway that we doing the lecture series. And this week is last week for the CT modality. And we are going to talk about dual energy spectral CT and also cardiac CTA, which is a very difficult topic in my opinion, because we need to get a good image quality in the small size of the cardiac vessels, and we need to compete with the heartbeat to get a good image quality. And most of the time, patients get a high radiation dose. So you're gonna teach us how to get a good imaging quality with the optimal radiation dose on the cardiac CTA. So, welcome.
Thank you. I'm glad to be back. So just like Tanya said, we're gonna try to finish off our CT module this week. I am just gonna get my screen. All right, now you should be able to see what I'm seeing. All right, so thank you Tanya for the introduction. So a little different this week. In the last couple of weeks, the first talk was focused on image quality, and then the second talk was focused on radiation dose optimization. But because we have two topics this week, for each talk, the first talk, I'm going to talk both image quality and dose optimization. And as Tanya mentioned, we're going to first start talking about dual energy CT, and then after the question and answer period for dual energy, we'll jump into the cardiac topic. So let's get into dual energy. Now let's talk image quality optimization. So from the very beginning, here we go. There we go. Sorry, it didn't want to work. So when you consider dual energy, what we're basically doing is we're going to scan the same tissue twice, but we're using two different energies of radiation, or two different X-ray energies, so two different KVs. And from the very beginning of the development of CT, Dr. Hounsfield always envisioned using two energies to scan the body, because he realized from the very beginning, all the way back in 1970 when CT was invented, that if you image two pieces of one tissue twice with two different energies, you can distinguish and identify the type of atomic energy or atomic mass of the image. And so if you know how it looks, and because of one energy of because you image with two different energies, you can identify, for example, the difference between iodine and calcium. just as an example. And so dual energy CT has actually been around for a very, very long time. The only reason we've only started using it now is because CT scanners weren't powerful enough back in the day, nor were the computers really capable of doing the reconstruction. So really dual energy CT, as we know it, actually began in about 2006. And that was when the first of all the various different CT vendors introduced a CT scanner. Siemens was the first to introduce a dual energy CT scanner. So to understand how to optimize dual energy CT, we need to talk just 1 or 2 slides about fundamental physics. And so we all know, you've all been taught this in school, that the way we create an image using X-rays is the photon comes in and it will interact with the body. It'll either fully attenuate, and that's why the image looks, that tissue looks white, such as bone, or it might pass through the body and go straight to the detector, and therefore it'll look black, such as air or lung areas of lung tissue. And so what we're basically doing is we're measuring the attenuation effects as the radiation passes through each voxel or each part of our body. And radiation interacts with our body in one of 3 fundamental ways, either with Compton scatter, photoelectric effect, or coherent scatter. And we know that the radiation, as it interacts with our body, is energy dependent. So if you look along the bottom, along this x-axis, so you go from low energy to high energy, in this, in this area, from this purple line to the right, this is the CT range. So if you use 120 kV or an 80 kV, 80 kV would be on the low end, 120 kV obviously would be on the high end. And it just depends on the type of tissue. For example, here's muscle and cortical bone, and the energy as to which type of interaction the X-ray will undergo. So for muscle, if it's a relatively high energy, it's predominantly going to interact with Compton scatter, and there's going to be very little, if any, photoelectric effect. And conversely, when you look at cortical bone, if you're somewhere in the middle to low range, you're going to definitely have Compton scatter, but you might have a little bit more photoelectric effect. So why does this matter? Well, here I have the same phantom with various different inserts. And what I've done is we've scanned it with 140 kV and then similarly at 80 kV. And so you can see the color of the frame of each of these boxes. And I just roughly circled kind of where on this attenuation curve they would lie. So at 140 kV, basically we're only imaging this phantom using Compton scatter effects. But over here at 80 kV, you definitely have Compton scatter, but you get more photoelectric effect. And so when you look at these 2 images, the first thing you notice is at 140 kV, you probably can't distinguish the difference between the material of these 2 objects. But at 80 kV, they look different. So there's a reason they look different, because they're obviously different materials. So here I'm just simply going to reveal to you that it's an iodine plug at the top of this phantom and a calcium plug at the bottom. Now, until I told you that, you wouldn't know what the material is. But because this iodine, you can see here how iodine when the X-rays interact with iodine, it appeared differently at 2 different energies. Calcium is subtly different, but not as much. And this is the fundamental reason we can create an image with dual energy, is that each material will look slightly different at different energies. Now, you've probably noticed this effect if you've ever put an ROI in an image. So it's just a normal clinical image that we've created. And if it's, for example, bone, and we acquire it at, let's say, 120 kV, this red circle, well, that CT number is going to be a value. Let's say it's 900. Now, if we've imaged that exact same person or object, and we put the ROI in their bone, their CT number is going to be higher, much higher. It's going to be over 1,000 Hounsfield units. And so the idea that the CT numbers would change with different energies is that fundamental reason, because there are different attenuation coefficients for each of these tissues. And all of that is because we image with a polychromatic Bremsstrahlung radiation. Therefore, all of the X-rays exiting the X-ray tube have a very wide spectrum of energies, all the way from high energy down to low energy. We're not using monochromatic or a single vertical line, but polychromatic. And so therefore, each of these photons will interact with our body slightly differently. And you can see that depending if we image with 80 kV, which is this orange curve, versus blue at 140, there's different quantities of energies. So at 80 kV, there are more low energy X-rays, and blue curve, we're at a high kV, 140, there are more high energy kVs. And this is going to be very important as we need a combination of both of those to distinguish the materials. So, as I mentioned, what we're going to do is we're going to acquire two images at the exact same location in the body at two different photon energies. So typically for the low energy, we're going to dial in about 70 or 80 kV. And that's what gives us, for example, this orange looking curve. And then for the high energy, we're going to be somewhere at 140 kV. And some of the newer scanners can even go up to 150. The whole thing, the main goal of dual energy CT by imaging at a low and a high kV is we're trying to separate these two spectrums as much as possible. So you want the high kV to have predominantly high energies and few low energies, and conversely, the low energy, more low energies and high energies. The areas where they overlap, the system cannot distinguish what that photon from the next. So if you get this energy, let's say 80 kV, you can see there are a fair amount of photons both at the 140 generated from the 140 kV and 100 kV, but the system has no way to distinguish the difference between the two of them. So what we want to do is we want to separate those two curves as much as possible. Now, the other aspect of this is it depends on the atomic number of the material we're trying to identify. And so what we're going to do here, as you see in this image of the neck, the thyroid is somewhat enhanced. And so it's going to have probably some iodine in it. And therefore, when we actually put ROIs in it and we image it at different energies, it's going to have a spectrum. It's going to be either not as bright, so more gray at the higher energies, but it's going to be much more intense or brighter, whiter at the lower energies. Now, the same could be said about the muscle, but muscle doesn't really infuse with iodine. So therefore, it's mostly going to stay the same iso gray color at all energies. And so if we're trying to distinguish the difference between a high atomic number, such as iodine infused tissue, and a low atomic number, such as just water equivalent soft tissue, we can do that really well because those two curves are very different. But that you see dual energy CT scanners that can identify the difference between muscle and say breast tissue or fat or lung is because this tissue is basically, it all has the same atomic number. So what we're going to do in dual energy is we're going to look at very distinct atomic structures, such as an example, iodine and calcium. So what we can do is we can go in and we can take, if we want to create a reconstruction algorithm that will identify iodine and distinguish it from calcium, what we can do is we'll take a variety of different iodine concentration samples and we'll measure them first at 140 kV, and then we'll do the exact same thing. We'll image them at 80 kV. And as we do that, we plot along this curve a response curve for iodine at these two energies. And we do the same thing with calcium, and we can do it for multiple different tissue types and objects. And what we do is we create all of these various different curves. And the fact that these two curves are separated gives us the ability to distinguish the two. So once again, we can either go through and actually measure all of these tissue types or these various different concentrations of different materials, or you can actually go. Now, I don't know if the Thai government has something equivalent to what we have here in the US. But we have a website that it's the National Institute of Standards and Technology. And you can go on and they've already done all of this work. They've looked at how iodine, different concentrations of iodine at different energies, and they have all of the curves and all the tables. And so you can just take the numbers and put them into the CT scanner. And you can do this obviously for iodine, calcium, you could do it for gadolinium, you could do it for whatever you want to measure in the body, as long as there's enough of a difference. Now, what you need to understand is you need enough difference. Here you can see obviously this iodine is along this dashed line, calcium along this solid line. But the reality is every one of our CT scans, they are not perfectly noise-free. And because there's a little bit of variation every time we acquire an image of someone, that means the CT number could be a little different. So there's a little bit of variation. And that's why you see this broad spectrum, this pink red spectrum here and this blue. You need to have these two lines separated just enough that we can take into account the uncertainty due to image noise in CT scanners. All right, so now we've been talking about what we need to do is we need a good separation between these two objects or these two materials so we can get a good clean separation, reconstruction, and then in that reconstruction we can tell which one is iodine and calcium. Now, the more separated these two spectrums are, the better. The 80 kDV is on one side and the 140 is on the other side. As what that does is it shifts these curves farther away from each other. And so CT scanners that actually have a good way of separating these two curves will give us a much cleaner and more accurate calculation of what those different material types are in the body. And so once we have that, and we are basically going to go through and do some math, and I'm not going to go through all the explanation, but just simply what we're doing here is we have now two materials that we want to understand what they are, because we don't know what they are. We just know what their intensity is that we measure on our detector. And we've measured them at a low energy and a high energy. So we have two equations. So if you have two unknowns, you need, as you may recall from mathematics, you need two equations. And so we have that. And now what we can do is we can solve these equations for every voxel in our body, and we could create these sinograms specific for those materials that we're interested in understanding. So here I just give you a sinogram that is separated just for bone, and one is just for water. You know, they're not perfect separations, and that's just because, you know, the material that the atomic structure of water, obviously water has hydrogen and oxygen. Well, bone is going to have some of that material in it too. Obviously, it's mostly calcium, but it's going to have some low atomic energy components to it. So there's never a perfect separation of all materials, but it's pretty good because they are atomic. Their effective atomic number is distinguished enough. You know, bone is real high, water, of course, is real low. We can still do a really good job identifying them. All right, so issues in dual energy CT that reduce material decomposition accuracy, or the ability for us to identify two distinct materials, is the overlapping beam spectrum. Another one is, as I kind of mentioned, image noise. So if we don't use enough photons to collect onto our detector, then there's going to be some uncertainty. Remember, there's that spread, that red and blue curve, there was that spread. So and the image noise is much more prominent in lower kV images. And then of course there's always artifacts. One artifact that is very prominent, well, not prominent, that is detrimental in dual energy is the beam hardening artifact. And that is when, as you may recall from way back in graduate school or in medical school, when a photon enters the body, it's going to interact with that tissue. And so if you have a spectrum that is predominantly low energy, those lower energy photons are going to be mostly absorbed in the body, and only the higher energy component of that spectrum will exit and get on and collect onto the detector. And so it quote unquote hardens the beam. And so the beam shifts to a higher half value layer. And because the spectrum changes as it goes through our body, this is what causes beam hardening artifacts. Now, we want the distinction between one energy spectrum and another energy spectrum. But the thing is, we don't want those spectrums to be changing through our body. We want them to be mostly the same so that we can rely on the fact that we kind of know what an 80 kV spectrum looks like and a 140 kV spectrum. So we have to correct for that beam hardening effect. And then the final thing is scatter. Obviously, scatter is noise in another way to say it, but you can actually have scatter effects that will affect the way we calculate dual energy. So these are the four fundamental things: overlapping beam spectrum, image noise, artifacts, and scatter, that we need to optimize when we create dual energy CT. So now that I've talked very broadly about the physics component of how we create or how we use two energies to create one image and use that to distinguish two different tissue types, now you are, I think, primed, or you are a little better prepared to talk about all of the different CT scanners out on the market. Every vendor approaches their way they use dual energy differently. And because of that, you have to understand the pros and the cons to how they do it, because as I mentioned, there are four fundamental things we need to take into account, and each of them do it differently. Excuse me. So we're just going to go through all of the major vendors, CT scanners, and we're going to talk about the advantages and disadvantages as to how they create a dual energy CT scan. And then on the back side, through all of that, we're going to talk about how to optimize the image. So first one is Siemens. They were the first to come to market to really attempt to make dual energy CT scanning something we can do for every patient in the clinic. And they decided to create a CT scanner with two X-ray tubes and obviously two detector rings. And so each of the tubes could operate independently. One could operate at a low energy and the other one could operate at a high energy. So this is going to fundamentally give you the best distinction of these two spectrums, because these two X-ray tubes can work they operate independently. And therefore it increases the quantitative accuracy of the dual energy image thanks to their better separation of these low and high energy spectrums. You also get really good noise control because you can independently increase the MA or decrease the MA per X-ray tube so that you get the right amount of signal at each detector without too much noise. So what are the limitations to a two X-ray tube or a dual source CT scanner? Well, the very first limitation is because there is finite space inside the gantry. You can kind of see here, one X-ray tube has a wider detector ring than the other one. And so tube A, for example, can image more of a patient than tube B. And so when you operate a Siemens CT scanner and you use dual energy, they always place a circle over the body. And what that means is you can do dual energy inside this circle, but not on the outside. And that is just simply because that second X-ray detector is shorter than the first one. So there's a fundamental limitation to the field of view in which you can do dual energy. Of course, you can actually acquire an image that is what we call single energy or traditional image, but you will not be able to classify the tissue outside of that circle. Now, the other issue is scatter. If you have one X-ray tube and you get photons that come in here and interact with this body, well, those photons can actually scatter to the other detector. And so you have twice the amount of detectors, you obviously are going to have twice the opportunity for more scatter. And then finally, the fact of the matter is that the scanner itself, the X-ray tubes themselves are 90 degrees apart. In other words, as you image through this part of the body with this kV, and then you spin around and you image the other part of the body with a different kV, so one at, let's say 80 and another at 140, well, that's fine. But at one instant in time, this scanner will never image the same tissue with two X-ray energies. Now remember, fundamentally, all the way back to Dr. Hounsfield, 1973, the goal here is to image the same tissue twice. But in at one instant in time, you're never going to be able to do that because the tubes are 90 degrees apart from each other. So there's what we call spatial temporal limitations. Obviously, they're very close to each other at 90 degrees. You only have to spin the tube a quarter of the way before you can image that same piece of tissue. But if you're doing something with, say, moving, such as your heart, obviously the heart has moved, so that therefore the tissues are just going to not be aligned. It can go really fast because 70 milliseconds is all it really takes to go from one to go 90 degrees. But unfortunately, it's not perfect. All right, so GE and Canon. GE has done this from the beginning back in 2000, I believe, 12 or 2008 or 12, I think is when they came out with their first dual energy scanner. Canon only barely just changed over and decided to do what we call fast switching KV. So therefore, unless you have a brand new Canon CT scanner, they don't do this yet. So what this is you have one X-ray tube and one detector, but as it spins around the body, it is quickly changing from 80 to 140. It's quickly switching from low to high KV. And that is fine, but it just requires you to have it requires you to have a very fast acting CT generator, and you have to have very fast detector elements. They can collect the signal and get that signal out to the computer, and they have to be able to do it very quick because in a small fraction of an angle, it's already collecting data from a different KV. One of the major advantages of this is because it's one X-ray tube, one detector, you have the full 50 centimeter field of view as an option. You're not limited like the Siemens dual source scanner. The system actually, most of the time when in normal CT without dual energy, the X-ray tube will move about 3 degrees between projections. So it has to go all the way around the body 360 degrees and collect all that data, but it's not actually collecting data every angle. It's collecting it about every 3 degrees. In dual energy, it's actually collecting it much faster. It's more of a fine sampling as it spins around the body. And so there's actually only about a 0.2 millisecond difference between the low image acquired in one angle, and then as it moves just a hair, it moves a half a degree, it acquires then the high energy. And so it's very quick. When we talk about fast switching, we're talking fast switching within 0.2 milliseconds. So that is very quick, 200 microseconds. And because it is very finely sampling over the body, the fact that we are almost imaging the same piece of the tissue with 2 different KVs simultaneously. This gets really close, but it's still not exactly imaging the same piece of tissue twice at 2 different KVs. It's a little better than the Siemens scanner, but it's not perfect yet. And so therefore, because of this, you get really good, accurate material identification or decomposition. And so basically what it does is because you collect at 80 kV and then you go a little bit you spin just a little bit and you collect 140 and you spin again at 80, you're actually missing, if you think about it, every other set of projection data, you're missing a little bit of data in between. And so to create a full, complete, and accurate image, it interpolates between these very close half a degree different projection data. And so there's a lot of interpolation at the low energy and the high energy, but it makes it very quantitatively accurate. And it's able to reduce all of those beam hardening artifacts because of how fine it's sampling over the body as it spins around the patient. So what are the limitations? Well, with the two source CT scanner in the Siemens, you can, as I said, operate the X-ray tubes independently. So you can put different filters in them, and you can change the MA and the KV. And so you can really separate those spectrums. They're the best way to separate them is with the two tubes. There is also slight signal contamination. When you switch from 80 to 140, well, it's not perfect. It's not a perfect 80, then it turns off the 80, and then it goes to 140. And so that means sometimes as it spins from one half a degree to another half a degree, and it collects more data from the high energy as it goes from low to high, well, there may still be a little bit of low energy data still in that detector element when you switch over and start collecting it at a high energy. So there's what we call just a slight amount of signal contamination, as it's not able to perfectly switch from low to high instantaneously. It gets close. As we say, 0.2 milliseconds, that's pretty darn good. But it's, once again, it's not perfect. And so because it's not perfect, there's a little bit of contamination between the low and the high. Well, it reduces your accuracy of exactly determining the distinction between the two. If these two material types, say calcium and iodine, are very far separated, well, that's okay. Your accuracy is going to be pretty distinct. But the closer they are together, then you'll have a little bit more problem being able to accurately identify what the material is. And of course, there's going to be more noise issues in the calculation of this, and that's just because as it spins around, it's doing its best to switch from one kV to the next, but it can't change both the kV and the MA at the same time, and so it's going to have some inherent limitations to how many photons it can produce at the low energy and the high energy. And remember, we said that noise is an issue in creating these images, and the noise is most problematic at the low energies. So we'll talk a little bit about that more when we get into the dose calculations. But because the other thing is the speed limitation, as it's spinning around and it's doing a very fine sampling around the body, the tube, it just can't go too fast or it'll not be able to sample as finely. And so there's a fundamental limitation. You can only go as fast as a half a second full rotation around the body, which is fine for most tissue types. But if you're imaging the heart, usually that's not fast enough. And so that means there'll be just when you collect the heart at 180 and then you switch to 140, well, the heart tissue, of course, will have moved, and so they won't be perfectly aligned in space. All right, so going on to the Philips scanner, they are distinct in that they basically put two detectors on top of each other, and then they put a little bit of a filter in between. So what's happening here is you're going to only acquire the image using 1 kV. 1 kV, either 120 or 140. But because low energies will absorb preferentially in the top layer, and only high energy photons from that spectrum will make it to the second detector, we are theoretically giving the detectors two different energies of photons. And that is just simply because we know some attenuate, the low energies attenuate in one, and higher energies are able to penetrate through. Once again, this is a single X-ray tube and single detector configuration, so you have full field of view capacity to image. And probably one of the best advantages to this approach is the fact you're using a single kV, say 120 or 140 kV. That means you can do normal single energy CT imaging. And then if you say, hey, I can't really see what I want to see, I wonder if dual energy will give me more information, you can simply reconstruct it with dual energy because that data is there. For the previous two CT scanners that we talked about, you have to, when the patient gets on the table, you have to pick the dual energy protocol. the system has to know from the beginning that it's going to image both at a low and a high energy. But in this one, it's always imaging at one energy, and it's just collecting two different spectrums based on its detector configuration. So that is what I think, in my opinion, one of the greatest strengths of the Philips dual layer detectors is the fact that you can do dual energy CT on every patient, irrespective if you know a priori or beforehand if you even need that dual energy. And therefore, you don't need to build special protocols for dual energy. Everything is just inherently both single or dual energy. All right. This is the only time that you get perfect spatial temporal registration. Obviously, because the Siemens scanner has two 90 degrees apart. They're never perfectly aligned. And the GE and Canon one, they're constantly switching, and so they're never perfectly aligned. But in this case, it's the same photon flux going through the body, always the same as it spins around the body. Therefore, it's perfectly registered spatially and temporally. And so it's really good for imaging and doing dual energy for something that's moving, such as the heart, or if you have injected contrast. It's not a small thing because blood is actually flowing in our body when we create an image of, say, the liver, and we want to look at it, I don't know, in the arterial phase. Well, blood is actually moving. And so if there's a subtle difference in time from one image to the next, low kV to high kV, well, they're going to be subtly different intensities. And so it introduces a little bit of uncertainty. Now, there was a study published back in 2017. And what they basically did is they took 118 patients and they performed them all just using the scanner. And what they basically said was, okay, we collected all the data, and then they said, okay, answer this question. Do you, after you look at the data, would you need more information? Would you use the dual energy information, or would you simply just stay with the single energy traditional looking image? And of those 118 patients, they ultimately felt, the doctors, the radiologists that did this, they felt that they needed more dual energy information than just the simple gray and white image. So 80% of those actually used the dual energy CT image data. But when you look at the patient history, only 20% of those patients would have been protocoled for a dual energy CT. So if these same 118 patients had been imaged on either the two previous scanners, then we would not have imaged 60% of them with the right. We would have left out 60% of the data, and the radiologist would have been just left with less information. So what that study demonstrated was that radiologists actually would prefer to have more information coming from dual energy consistently instead of the way we do it now, which is we simply protocol it based on patient history. All right, so because these are spatially temporally aligned or registered, it's very quantitatively accurate with fewer artifacts, and the noise in the images it has very, very low energy, noise in these images. We haven't talked about the monoenergetic the monoenergetic or mono E images yet, and we will. But one of the advantages of reconstructing with dual energy is obviously you can determine which material is which, calcium, iodine. But we can also create different looking images. We can create really high contrasty, low mono E images, and we can create low contrast, but low noise. So let me start over. High contrast, which tends to be high noise, and low contrast, but tends to be noise free. That is true for everyone except for Philips. Philips, it basically has no noise in all of those images. And you'll see some examples later of patient data where when imaged on a different scanner, these lower effective energy, these low mono E images are really noisy, but they have a much more intense contrast. You can see this stent right here. It is much more intense. And as you can just imagine throughout the entire body, wherever there was iodine or bone, it would just be more intense. Limitation is because you're actually only using 1 kV and you're artificially trying to separate it. There is a lot of overlap when you look at the two detectors and their spectrums. And so because of that, there is a penalty to the amount, the types of tissues you can differentiate. All right. The next one is the traditional Canon scanner. So if you have a Canon scanner now that's more than a couple years old, this is how you would do a dual energy. Basically what it is it will spin over the body twice. So once again, you're able to image with 1 kV, and then it switches and it goes over the exact same location a second time. And so this is fundamentally what Dr. Hounsfield said. Same tissue, imaged at 2 kVs. The way it does this is actually at a very, very low pitch. So the body is constantly but slowly moving through the gantry, and the system is just spinning. And it's every time it goes around the body, it changes from low to high to low to high to low to high. And so every tissue type gets imaged twice. Because of this, you get nice noise characterization. The limitation, obviously, is that it takes the amount of time for it to spin all the way around, to switch kV to spin back all the way around. And so if you're imaging something that's fast moving, such as heart or blood that's transfused or perfusing through the body with the iodine in it, those moving objects are not going to be spatially temporally registered. And so you'll see just artifacts, and you'll see misregistration in the image. And then finally, in somewhat the same way, a patient with low pitch, very slowly moving through the body, through the scanner. Well, this Siemens system came out and they basically put a very specialized filter on the end of the X-ray tube. Most bow tie filters, almost all bow tie filters, are primarily aluminum. They may have some other materials there to help it, but mostly they're aluminum. And so this one, it took half of the filter and used tin, and the other half, it put a teeny layer of gold on it. And because these two materials, in addition to aluminum, are there, they each have different attenuation profiles. They basically split the beam. And so as photons pass through this side, they'll have one energy spectrum. And as they pass through this side, they'll have a completely different energy spectrum, high versus low. And that's great. And so basically you can take this filter and stick it in any X-ray tube. It's a single tube, single detector. So you're imaging with 1 kV, and you're imaging with the full 50 centimeter field of view. It doesn't take very special scanners. There are no limitations on how slow or how fast you can rotate, so it's all nice. The biggest limitation to this, once again, obviously, is it's slowly passing through, the body is slowly passing through the CT scanner, so nothing is perfectly registered, spatially temporally. There can be scatter effects from the low to high side of the filter as it goes through the body and onto the detector. And because gold and tin they have different attenuation. Gold is actually a very highly attenuating material, as so is tin, but they attenuate slightly differently. That means you actually have to turn the MA up real high so you get really high photon flux coming through. Now, all of those photons aren't actually hitting the body because a lot of them are being absorbed in the filter. And therefore, the system is just fundamentally limited on how big a patient it can image. If you have a really big obese patient, then this system will not be able to provide the right amount of photons coming out of the X-ray tube. Now, last week, someone asked if we could talk about Hitachi. And similarly, the question would be, what about the other scanners? Do they also do dual energy CT? So Shimadzu, Hitachi, United Imaging from China. These are wonderful CT scanners in their own right. And I went out and I actually spent a couple of hours. I was digging and digging and digging, trying to find all the information I can on these 3 scanners. These are not very typical here in the US. You probably see them a little bit more over in the Indochina, Asia area. That said, they all said they can do dual energy imaging, but there's really nothing in the literature. So unfortunately, I couldn't really give you a lot of information about these 3 scanners. My guess is they all have similar either fast switching or spin-spin acquisition types for dual energy. So not a lot that I can report, but I think that's actually a great invitation for you all. If you go out here in the US and you try to publish papers on Philips and a Siemens scanner, there's actually a lot of publications on there. So it's harder to publish that data. A lot of people know about those scanners and how they react and work for patients. You guys actually would do a great service to the scientific community if you have a Shimadzu, Hitachi, or a UI image CT scanner, and you were interested in developing the dual energy capacity of those scanners, publish that information and get it out into the literature. And people like us over here in the US or, in the West, that would actually be very helpful for us. And so I just say that's an invitation to you. Unfortunately, I cannot give you more information. I just could not find it in the literature. Now, I'm sure there's some out there, and I just I didn't read every journal, but I did spend quite a few hours going through using Google and looking for the PubMed and all the various different publication avenues. And I just was unsuccessful. So my apologies. I know there was a request to have some Hitachi data. All right. So we've talked about the fundamental physics of how to create the image. We talked about the 4 fundamental things we need to optimize. And then we talked about how each CT vendor has a different approach to creating dual energy. So it is incredibly complex, this process of using dual energy. Obviously, there's 4 things we need to optimize, but you have to know which scanner you're using and how it acquires the images so we can actually optimize those 4 things. But before we get into that, let's talk a little bit more broadly. What does dual energy provide? If we understand kind of what we're trying to get, the information we're trying to get out of the image, then we kind of know a little bit what we need to do, how to create the image and how to optimize these 4 things. So the first thing is it was the first thing I think that they developed dual energy for, which was the differentiation of uric and non-uric acid stones. And here you can see an example of an acquisition, and it's a dual energy. You can see it was a Siemens scanner. You see that yellow line telling you this is dual energy in here and no dual energy out here. So obviously it's got to pretty darn important to get your kidneys inside that, in this case, get inside that circle, or you won't be able to differentiate the stone itself. Distinguishing between the 2 is very easy. Well, I would say very easy. It's highly accurate. But differentiating the different types of non-uric acid stones is still kind of a work in progress. The problem is when you look at these various different types of non-uric acid stones, they all basically have the same effective atomic number. And therefore, they basically have the same attenuation pattern. So when it comes to this stone identification, we're really looking at the difference between, is it uric or non-uric? In other words, will you have relapse issues? And it just depends on how you triage the patient for treatment. And I know you know that, you're the radiologist. Another thing is gout. So looking at, kind of inflammation, arthritis type issues, gout, it can be by the uric acid crystals versus pseudo-gout, which is be characterized by more of a calcium buildup. And so once again, you got the distinct difference between these 2 objects and their atomic numbers and their attenuation profiles. And so when you image the body, you can very easily identify and color code here what a uric acid would look like here shown in green versus calcium or a pseudo-gout shown in purple. Just another example, as I was looking through some of the publications, this is an MRI on the left and a woman that has been going through breast cancer. She had a lumpectomy and a larger, actually a mastectomy. And so they placed in a silicone breast implant, and they were looking for extracapillary silicone leakage. So it's very obvious in an MRI, but in a CT, a plain CT, it wouldn't be as obvious. Dual energy, of course, silicone versus soft tissue is highly differentiable. So it's something we can distinguish very quickly, just as an example. What else can we do? Well, if you have 2 distinct objects with two distinct atomic numbers, you can quite literally subtract one of those out of the reconstructed image. So you can do bone subtraction, you can do iodine subtraction, and get what we call a virtual non-contrast image. So instead of doing a two-phase liver study or a two-phase abdominal study where you image without the contrast, then inject them and image them again, in this case, you can inject them with the iodine contrast, image them, and then physically subtract the iodine out of the image and get this virtual non-contrast. And then, as I've been demonstrating through and talking about this, if the tissue, if the materials are distinct enough, we can actually identify them, and so therefore we can color code it. So if you're looking at, calcium versus iodine, or uric versus non-uric, you can actually create these pseudo color plots and demonstrate that as an overlay to the actual grayscale reconstructed image. Because of the way the image is acquired using both low and high energy, and because artifacts are different at the low energy KVs and the high energy KV, we can more readily identify beam hardening artifacts and other types of artifacts in dual energy, and not very easily once again, but more appropriately reduce those energies, those artifacts in the image. So you can actually do pretty good, in this case, metal artifact suppression in what's called single energy. All the vendors have this option, but it's not perfect. You see the residual effects. But with dual energy, you can see how it almost completely gets rid of all of that streaking and beam hardening artifact. So dual energy can be pretty artifact free when you calculate, when you develop it right or reconstruct it right. And then finally, we talked a little about creating what are called monoenergetic maps. Basically what that is you take the low energy spectrum images data and the high energy data and you blend them together. If you use more low energy information to reconstruct the image, you'll have a lower mono E. And if you use more of the high energy to create and a little bit of the low, you'll have a higher mono E image. And the obvious that you see here when you look from low to high is the lower energy mono E images have very strong contrast. Obviously, this is a contrast diffused image. The kidneys are just as bright as can be. The liver and spleen are much brighter, and you can even see the vasculature. But as I mentioned, for most vendors, with Philips being the only one with the exception, because it's a lower energy, you have a lot more image noise. And so sometimes it can be harder to read through these images. But if you look at the higher energy, you lose your contrast. The liver and the spleen are almost look iso dense in the grayscale, but it's much cleaner. And so this is one of the benefits where, in my opinion, identification of uric and non-uric in pediatrics is really not that big of a deal. And hopefully we're not really dealing with gout with kids. Some may do have arthritis issues, but for the most part, those tend to be usages or protocols that we would create for adults. And so oftentimes as a pediatric physicist, everyone asks me, well, what do you use dual energy for in kids? I tell them this is probably one of the most important, this is one of the main reasons why I would use dual energy in kids is the fact that you can get 5 or 6 or 7 different views or looks or different types of ways to look at that child's image, but for the price of just one image. And so if you are trying to look at a high contrast image, but you also think, it's too noisy, so you can just simply dial it back and you can look at a less noisy image, or if you want to keep dialing it. So instead of, you can window and level in it using your mouse, right? You can window and level, it goes gray, and it changes the grayscale. In this case, you can also shift it left to right, and you can change the contrast effect in the image. So it's actually very powerful. There's just a lot of information. In a monoenergetic image, the 70 kV, which is basically in the middle, is equivalent to a 120 kV image. So in a single energy CT scanner, traditional 120 kV acquired image, if you look at the 70 kV, they're mostly comparable. Now, with this ability to physically look at an image and make it look more contrasty and less contrasty, one of the other benefits to this is we do not need as much IV contrast when we do dual energy CT. And so for someone that might have renal functional impairment, but you still want to do an IV and do an iodine contrast enhanced CT, well, that's fine. Maybe you can dial back the amount, you can dilute the concentration, or just simply, obviously just use less IV. And then you can still, so if you would normally do that in a single energy CT scan, it might look more like this, or it might look more like this over at the high energy. And as a radiologist, you can't see the vasculature, and it's a subpar, it's a suboptimal image. But if it's dual energy, all you have to do is just dial to a lower effective, a lower mono E, and boom, there's your vasculature. So that's one of the that's one of the benefits, obviously for adults if they have renal impairment, but also for kids too. All right, so how do we accurately interpret material subtracted images? Well, first, let's talk about some misconceptions. The first one is, if we're going to measure, so if we look at an image with iodine concentration mapped onto it, if you draw an ROI on it, it's not actually it's not going to tell you the exact concentration of the iodine in that location. So you might be looking for iodine uptake in, say, a tumor or some kind of lesion. It's not perfectly, if the ROI wouldn't tell you the exact concentration of iodine, because obviously the iodine is mixed in with the blood. So you just have to remember, just because you see the iodine and it's very intense, that doesn't necessarily mean it's a perfect and one-to-one correlation of the actual concentration of that material in the body. Also, because these virtual non-contrast image, when you're physically subtracting out the iodine component, all voxels in the image are a mixture of different materials. And so, for example, the liver itself, when you infuse it with iodine, every voxel is going to have some soft tissue in it, might even have some fatty uptake in it locally, and it'll have iodine. And so when you reconstruct it, the appearance of it is a combination of all of those atomic numbers, all of those materials in one. And so if you simply subtract one out, well, it's obviously going to look different. Well, apparently you get rid of the contrast, so it's a virtual non-contrast image. But you're also taking some of the information away. So if you put an ROI on any one of the tissues and you want to look at the CT number, well, the CT number is going to be inherently different than it would be if you acquired the image a true non-contrast single energy CT. Therefore, the fats, the muscles, the CT numbers themselves are going to be subtly different in a virtual non-contrast image acquired with dual energy than they would with a single energy true non-contrast image. And so looking a little bit further into that, a publication by Mahmoud that came out in 2018, is they looked at, I can't remember, 100 or more, a couple hundred patients. And what they did is they looked at the true unenhanced images. So this column right here, this first column, these are patients that were imaged without any IV contrast on board. So what would be considered a true unenhanced image. Then in the center here, these are patients that were imaged with dual energy. And so these patients had contrast on board and they were acquired with contrast, but then we mathematically subtracted it and this is called the virtual non-contrast. And then we have different ways. Once we've identified which tissue, if we remember those two curves, if we're trying to identify iodine as one of those curves and maybe, soft tissue or water as another curve, well, what we can do is we can do a plot where we simply just look at the plot where it's got the density of water, or we could do the density of iodine. So it's subtly different than the virtual non-contrast. I'm not going to really get into the difference of it, but there's just a different way of looking at the image without iodine in it. Just a different way of reconstructing it. So in this case, they looked at a couple of different things. Hemorrhagic cysts down here at the bottom. They looked at hypodense lesions and then focal fat in the liver. And what you see in the true unenhanced, you see the cyst, you see the hypodense lesion and the focal fat here. But for the virtual non-contrast and the material density maps, the cysts are you can't see them. And it's arguable that you can't see the hypo here. It's maybe there, but maybe not. And then the focal fat is not present too. So it's not always perfectly true that you can just subtract. Like I said, when you subtract out the iodine, you're also fundamentally changing the way the image looks when you reconstruct it. Now, the one caveat to this, and they mentioned this in their publication, was when they acquired the dual energy images and then did the virtual non-contrast, they actually acquired it in an arterial phase. So potentially, and some other people have published this and have said that it's potentially possible that had they done a portal venous phase and then did the subtraction of the virtual non-contrast, subtracted the iodine, that maybe these hypodense and maybe the cystic hemorrhagic cyst would appear. So this goes to show you that when we're optimizing and creating dual energy protocols, not only do we have to figure out which KVs we're using and how much radiation we're using to create the image, we also have to figure out what the timing is. Do we use the dual energy at the arterial phase, the portal venous, the delayed? Do we acquire them all three? All of this information needs to come into it because there are some clinical issues that may not be apparent in one or the other options. And so there's still a lot of information we don't understand exactly how we use and protocol for dual energy. All right, so when we consider the monoenergetic images, if you look at the 70 kV mono E, remember that's the most similar to a true quote unquote 120 kV image. If you look at them, in a different actually in that same publication with Mahmoud, the radiologists looked at them and they were asked to consider the vascularity. How conspicuous is it? Was it sharp? Was it well defined, etc.? And so when they looked at the water iodine maps and then the iodine overlay map, so it's a nice grayscale image, but the system has identified what is iodine and what is water, and it does a pseudo color over the iodine area. Basically, every radiologist said they preferred the water images right here, the iodine images where you subtract the water information out and or you simply do a pseudo coloring over top of the vasculature. And that, in their case, made the vascularity of the image appear more conspicuous and just more intense to the eye. It was more pleasing. So monoenergetic imaging is also very beneficial if you want to make something stand out a little better in the image. So let's talk a little bit about how do we optimize dual energy CT protocols. Attenuation really needs to be paid to the very low kV setting. Of the two spectrums we're going to acquire, let's look at the low kV setting. Low kV settings have the most, that's where most of the noise is found. So the noise is most prominent, most intense, which we've seen. That's where most of the artifacts are found. And then the quantification accuracy is the most difficult at the low kV settings. So how do we handle image noise in dual energy CT? Well, we can actually use different reconstruction techniques. We can use iterative reconstruction, which is standard on all CT scanners now. And therefore, we can both clean up the low energy and the high kV images. Where it's possible, there's been many publications out there demonstrating different types of reconstruction. And if your vendor has those types of reconstructions algorithms, you should use those. So that's one of those things you'll just have to, depending on if you're Siemens, Canon, Hitachi, whoever you own, whichever scanner you own, you need to then just ask them what their different types of reconstruction algorithms are available. If you're just using the same filter back projection or iterative reconstruction, you may realize that there is actually something else out there that's better. Now, when you go to set the right amount of noise in the image, you may ask yourself, well, how do I do that? I've got two energies, and how do I optimize the noise in both of these energies? Well, luckily, the CT scanner does most of this. The vendors, before they even sold you the scanner, they did a lot of research and they built a lot of different algorithms in the background. So what you typically do is you'll sit up and you'll decide what type of noise I would want in a traditional 120 kV single energy CT, just a normal looking image that you would acquire every day if you didn't have dual energy. How much noise can you tolerate? And you will establish that noise target value. Now, remember from last week, all vendors have different noise indices. You know, GE calls them noise index, Canon calls it SD, Siemens, Philips, Hitachi. They all have their own way of defining the noise. So you would set that for each of those independent vendors the way you normally would do it. And then the system will calculate what that volume CTDI would be for that noise index. And then the system, when you turn on the dual energy, will then optimize the right amount of MA for the low and the high setting, doing its best to match that same volume CTDI. And so it's doing its best to try to keep the dose, quote unquote, output the same between the two spectrums. Now, the resulting noise then would be the 70 keV mono E image should be similar to 120 kV single energy CT. So once you've done that, you've set your noise index and you've set up your protocol. If you image, for example, a phantom or something, what you want to immediately do is look at your 70 keV mono E image and compare it to an image that you acquire with 120 kV single energy. If the noises are the same, then you've actually optimized it appropriately. So how do we maximize the accuracy, the quantification accuracy? Well, this is actually something that we've kind of talked about throughout this whole process, establishing diagnostic reference levels. You need to have a good understanding of the CT scanner, its strengths and its weaknesses. And to do this, you need a robust quality control QC program. And one way to do that is to get a phantom and to scan that phantom. And this phantom has to have multiple sensitometry inserts. So this Phantom Lab phantom you can buy, it has one of these cylindrical rings that has a variety of different material types inserted in it. The Gamix Phantom has the same thing. You can actually pull these out and change the configuration, which you cannot do with the Phantom Lab. You can even add your own. The Phantom that I have, I can put water inserts, or I can get ones with a variety of different iodine or calcium inserts. And the CIRS Phantom is very much like the Gamix Phantom. It's various different inserts. You can change the location of it. The difference is their Phantom is more quote unquote anthropomorphic. It's more oval, whereas this Gamix is just a big circle. It's a big cylinder. And so by imaging these phantoms on your scanner and doing it over time, you'd establish the reproducibility of your CT scanner, but you're also able to help establish the right noise levels and all of that. And so having these phantoms are actually a very good first step for a good quality program. So just in summary, what are the benefits of multi-energy? Well, we've talked about better differentiation and being able to identify the different types of materials in the image. So material decomposition or characterization or identification is kind of what we're trying to do. We want to improve the appearance of artifacts. And so dual energy CT actually removes a lot of these artifacts from the image. So they're mostly artifact free. And then better visualization of tissue contrast. And this is that idea where you can You can change the mono E so you get really good, intense, contrasty images versus noise-free images at the high end of the spectrum. You can, as we discussed, potentially reduce the amount of iodine IV that we inject into the body. It's just much better for our kidneys. Now, for the last few minutes of the talk, we're going to talk about the radiation dose optimization aspects of it. So just really briefly, let's talk about all of those major vendors again. So what is the advantage of using a Siemens dual source CT scanner? Because each X-ray tube operates independently, you can use the right MA for the low energy and the right MA for the high energy spectrum. And so you can manage the noise really well. And if you have a very big patient, you can penetrate them perfectly fine. You can use tube current modulation. So as it spins around, you can change the amount of MA you use for the thicker part versus the thinner part of the body. And obviously, I meant to delete that, but basically you're still limited with the field of view. All right, advantages for the fast switching is that the noise and dose, because it makes very fine changes as it switches around, as it spins around the body, very finely sampled, you can optimize the noise and dose very finely as it goes around the body. Now, you will spend a greater amount of time acquiring low energy. So it's not always perfectly maybe low, high, low, high. It might be low, low, high. The system will change the amount of times it uses low versus high, depending on how thick or thin the patient is. So it cannot do, the limitation is it cannot do tube current modulation in the sense that as we are, thicker through our shoulders, less thick through our chest, we don't need as much photons, MA through our lungs, and then our abdomen, of course, and our pelvis, we need more. It cannot change the MA as it goes down longitudinally through our body. And it therefore will it will set the MA to generate the right amount of noise in the low energy KV images. Now you might say, well, that's wasted photons at the high energy. So every time it acquires KV, 140 KV image, but at an MA that's optimized for 80, well, you're correct. That is just a waste of MA. You don't need it. But you have to do that because it can do a very quick switch between low and high KV, but it can't do a low switch MA. It can't switch the MA and then it cannot switch the KV and then switch the MA, switch the KV and switch the MA. It's very difficult doing that. So as the CT scanning technology improves, maybe one day they will be able to do that. All right, so one of the advantages of the dual layer is the fact that you can once again acquire the images like you would normally in a single energy. So you have tube current modulation. And then the advantages for the slow switching are that as it spins around, obviously you can change and modulate the MA very easily. So you have tube current modulation in that respect. And you can get the right MA for the right KV. And then advantages for the slow switching is that it's able to balance the right amount of MA as it goes through the body, has it basically tube current modulation. But we mentioned the major limitation for this is the photon flux. It's very hard to get the right amount of photons through these really thick filters. And so you really can't do very large, very obese patients. So what kind of doses are we talking about in dual energy? Well, historically, a decade or a decade and a half ago when we started doing this, dual energy CT was much higher dose than single energy. And so it was immediately developed for adults, almost never used in kids. And for the most part, we said that because there is more information in dual energy, improved CNR, improved material specification, therefore we can justify using higher amounts of radiation in patients just because we're getting more information. Now, with the advances in the dual energy CT technology, the most modern CT scanners, the radiation dose output for dual energy is basically the same as single energy. So I went through and I read a bunch of papers. And one of the things I tried to do is I went back and I just kind of went, 6 or so years back, and I started to look, 2015, 2016, 2017, how did the dose spectrums change as we move forward in time? And so as of about 2015, you can see here the dual energy, the CTD, the volume CTDIs are listed here compared to the low dose single energy CTs. And you can see they're basically the same. When you look at all 35, the aggregates average was identical. In 2017, a paper out of the European Journal of European Radiology, a older second generation dual energy CT scanner was still slightly higher in dose than the single energy. It was about 10% higher. But then in that same publication, they looked at a third generation, which was the most advanced dual source CT scanner they had. And the single energy was actually higher than the dual energy. The dual energy represented a 15% reduction to patients. In 2018, that Mahmoud paper I talked about, the single energy versus the dual energy was about 35% lower. And then in 2019, looking at these second generation dual energy CT scanners, there was about a 28% reduction. And then the third generation was an 8% reduction. So now a couple of things to point out was from 2017 with the second generation, where the dose is actually higher for the dual energy. Sorry, we'll go forward. You can see here after just a couple of years of fine tuning and optimizing the protocols, now even on these older dual energy CT scanners, we can get, I wrote those backwards. You can actually get dual energy now that's a little bit lower dose. My apologies. The dual energy is actually a little bit lower. At least I think it is. My apologies. I think I may have written that down wrong, but we'll just ignore that for now. But the third generation, the nice thing is look, we went from third generation where we were imaging at roughly 5 to 6 millisieverts. Now we're imaging at about 1.5 millisieverts. So even though the dose reduction wasn't as distinct going from single energy to dual energy, when you compare just going back a couple of years, so just 3 to 4 years, the new dual energy CT scanners are about 50 to 90% lower in dose compared to where they were just 5 years ago. So the overall dose reduction has come down. We are using radiation much more optimally and very little when it comes to dual energy. Now, when it comes to actually comparing the image quality, for example, looking at the 70 keV mono E images compared to a single energy 120 keV, you can see 25% reduction in radiation dose, and in this publication, 25% reduction in IV contrast. So you can maybe leverage that. Instead of doing all dose reduction, you can do contrast reduction too. And then finally, in another paper where they looked at what kind of dose reduction can you get when you're thinking about a clinical task, in this case, uric versus non-uric acid stones. In this case, dual energy CT, because those two objects pop out. The stone, obviously you see the stone in a single energy. Everyone can see stones because they're just little white dots in there. But being able to not only see the white dot, but determine if it's non-uric or uric acid based, you just don't need a lot of radiation. And so because of the additional diagnostic information in this paper back in as far back as 2016, and this paper as far back as 2012, they had already reduced the radiation dose substantially by 50 to 75%, and still were able to have the same diagnostic task, able to answer the same diagnostic task. So the most advanced dual energy CT scanners are basically dose neutral, and at times they are lower dose than single energy CT scanners. Now, the older model scanners, at least the ones that I wrote down right, I hope, are maybe a little bit higher dose than the single energy CT, but we're still learning to optimize those, even though they're an older model scanner. Obviously, dual energy provides an enhancement of image quality, so you get a much greater contrast to noise ratio, and you get much more diagnostic information. Therefore, in the cases where maybe the dual energy CT is just a little higher in dose than the single energy, one may argue still the benefit to risk ratio is much more tilted towards the benefit side. And then modern DECT protocols are highly optimized for, can be highly optimized for best patient dose experience. In other words, it's no longer just one dose for every patient. We're using tube current modulation. We're being able to adjust it for the size of the patient. So they've become much smarter scanners. Now, looking out and into literature, I could not find any diagnostic reference levels for dual energy CT. It's my understanding that even in Thailand, that's not something that you've approached yet. But that's the same in America, it's the same in Europe, it's the same everywhere else. And so this is a great opportunity that as Thailand now starts to install their dose tracking software throughout the country, maybe at probably the larger academic centers, you're probably going to do maybe more dual energy than your community centers. But as you start to collect this data on how you're using dual energy, and then how much radiation you're using in those scanners and the types of scanners you're using, you'll be able to then obviously establish your DRLs. But you'll also be able to look at the greater, broader image in all of Thailand as to how best to approach image quality and more specifically dose optimization for dual energy CT. All right, that's that. I went a little over. My apologies, Tanya.
That's good. Thank you so much, Sam, for giving us the overview about dual energy and spectral CT. And it's always an excellent talk from you about this aspect. So, what do you think about the future direction of the CT? I mean, in next 5 or 10 years, we're gonna have our hospital going to have dual energy or spectral CT, or do we?
In the US, there are some hospitals now that do all dual energy. It is probably going to be. So the one thing I did not talk about is because it's still mostly academic is photon counting. And that's where kind of like a nuclear medicine, we physically count how many photons come out of the body and collect in the gamma cameras and the PET scanners. We know exactly how many photons come out. Therefore, we can reconstruct the image specifically knowing how many photons are here and how many photons are here. We don't do that in CT. We just dump. It's like taking a big bucket of water and you just dump it on your head. It's hard to count how much water got your hair wet. In CT, it's just we can't count all those photons because we use so many photons. But in these newer CT scanners, we can actually, the detectors are fast enough, we can count how many photons we collect in every detector element. That's called photon counting CT. Mm-hmm. Photon counting CT is kind of the next future of where CT will be. Probably not for another 10 or more years. Excuse me, but photon counting is inherently the same as dual energy. Because we can count the amount of photons, we can also count or calculate the energy of the photon as it strikes the detector. So instead of doing dual energy, 1 energy and 2 energy, in photon counting, you actually can you calculate all of the energies on that spectrum. And so dual energy CT is kind of actually it's the stopgap. We go from single energy to dual energy. And once we figure out dual energy, when photon energy comes in, that's going to revolutionize all of the way we do CT imaging. So yes, I think that we will all eventually move towards dual energy CT imaging.
The reason I'm asking because right now we start collecting the data for the single energy, like the conventional machine. And then if in the next 5 or 10 years, our hospital or the trend of the CT going to be dual energy or spectral CT, so maybe we should start thinking, collect the data right now to have, to prep ourselves to be ready for the future.
The answer is yes. I mean, this is more in the future. So for what you guys are doing right now with the diagnostic reference levels in Thailand, you're collecting most of your information for single energy CT or traditional CT. But in the institutions in Thailand that do use dual energy, that would be very important to collect that data, because there will come a point, maybe in the next 5 years or so, where you will see more and more use of dual energy. Right now, we're still trying to figure out clinically what are the practical applications of dual energy. You know, stones, gout, these are things that are actually helpful diagnostically. But would you go buy a really expensive $2-3 million CT scanner to just image stones? I'm sure your hospital administrator would laugh at you, because you can do that with a single energy CT scanner. And so what we really need to do is develop the clinical application of dual energy outside of these, stones, uric acid, et cetera. Is there a room in oncology for dual energy? Is there a room in cardiology for dual energy, et cetera, et cetera, et cetera? And that hasn't quite been developed. So as we develop those two clinical questions, that's when you'll see dual energy used almost always. And that's where, as you start collecting all of this dose data, it'll be very helpful, because you'll already have some levels of data so you can set your DRLs in Thailand.
Yes. So we also have Dr. Panrutai to help us with the discussion sessions. And, do you want to ask something, Pan? Or?
I believe that in university hospitals in Thailand use dual energy CT. There's just starting the idea about the CTPA, and indeed the two hospitals trying to do the survey for the dual energy in CTPA, but probably about within these 2 weeks we will have the number.
That's awesome. That's wonderful.
But if it is possible and no problem with the collecting the data, we will spread about this Excel file for collecting data, but just only one about the CTPA.
Okay. Yeah. And that's, especially when it comes to diagnostic reference levels, you don't actually set a diagnostic reference level for every protocol you have in the hospital. Obviously, it's just there's too many. And so for example, you'll pick the top 10 most used protocols, and that's the ones that you send out to all the hospitals in Thailand. And so dual energy is one of those things where, like as Dr. Panrutai mentioned, is we're only doing a few of those in a few select academic centers. But as those academic centers publish their data and they go off and they teach and train, I think you'll see, like you talk about the CTPAs, that protocol might actually get used a little bit more universally in Thailand. And so having that data that's a great thing to have those dose values.
And may I ask about you said the dose from dual energy and single energy are about the same. So in pediatric patients, if in the larger children that we use 120 kV, and if we choose to do the dual energy, is that common in the US in the children's hospital or not? If we can make the dose not higher, and how about the image?
Yeah, and so that is the question that we've been trying to answer here in the US and in Europe too, all around the world, is there a reason to do dual energy in children? 5 to 10 years ago, the answer was no, because the dose was much higher. It's 2, sometimes 3 times as high as the single energy CT. And so no one really looked at it. But now, as you mentioned, the doses are about the same, especially for the larger kids. If you were going to image a teenager at 120 kV, and if you flipped it over and acquired that image in dual energy, the dose would probably be about the same if you're using one of the newer CT scanners. If you're still using a scanner that's maybe 5 or 10 years old, the dual energy output would probably still be higher. So that said, assuming the doses are neutral, why would we do dual energy in kids? Clinically, there's really not a there's not a what we call a silver bullet. There's not really that one indication that makes a lot of sense. You know, when you look at a kid with a kidney stone, if it's uric acid or non-uric acid, does that change the treatment? And at our hospital, it doesn't. And I'm sure it's the same through most hospitals. We just treat them all basically the same. And that's okay. That's fine. But as I mentioned, I think one of the strengths in dual energy CT, especially for pediatrics, but it's the same for adults, are the ability to do the it stopped moving. There we go. To being able to look at the same image, the same patient, a variety of different ways. And so looking at these monoenergetic images, if sometimes kids can be difficult. And so let's say we injected the IV, but we missed. Let's say we missed the portal venous phase. As a radiologist, you're looking over at the hepatic arteries and you can't see the hepatic arteries. That's a problem, right? But instead of going back and say, okay, let's repeat the image, but this time let's make sure we get our timing better. Instead, what you could do is you could just simply look at your 50 keV or your 60 keV, and then you can compare that to your quote unquote traditional 70 keV image, which is what it would look like in single energy. And hopefully, there you go. Maybe you can see the hepatic arteries and maybe the vasculature is there. So this is the one area I think for pediatrics, it makes the most sense. Is we could maybe dial down the amount of contrast that we use and we inject, and we could just have more information for you, the radiologist, to look at. Obviously, you're all busy. You're already looking at hundreds of images in single energy. Do you want to look at another 400 or 500 images in multi-energy? You know, that's something we have to figure out.
I think that in the case that we cannot get the intravenous access, that is very good, and like a slow flow injection or something.
Yeah. Yep. And so, yeah, but to be honest, here in the US, we do not do a lot of dual energy in kids. We just don't. And we're still looking for that. The doctors, the hospitals are still looking for that clinical indication that makes a lot of sense for dual energy. So hopefully we'll get there one day.
And I think there's some question from the audience.
Okay. Let's see.
So there is a question about the difference between monoenergetic and monochromatic images. So can you explain the difference on those things in depth to clarify the clinical useful of these two definitions?
Sure. Yes. And so looking at this slide, what you see on my screen, when we collect the data in the low energy, let's say 80 kV, and the high energy, 140 kV. So it's either spun around twice or we had our two tubes, however we collected the data. We now have data for hopefully every slice in the body at 2 energies. And what we simply can do to create these quote unquote monoenergetic maps is we just take a little bit of the low and we take a little bit of the high spectrum and we blend them together. If we have a lot more low, then the image will look like the lower monoenergetic maps. And so obviously, when you image a patient with a monochromatic or a single energy scan at, let's say, 80 kV, the image just looks much more intense. We talked about it last week, how you actually have to set your window and level differently, where the radiologist will look at the image and they'll get blown away. It's like looking into a light bulb. So the monoenergetic maps are simply just a ratio or a way to take the data from both spectrums and combine them in a unique way so that you can look at either high contrast or low contrast. Much more noisy images and the contrasty image, but less noisy at the high end, but lower to no contrast. If you want to compare what all of these monoenergetic images would look like if we collected them in the single energy, that is why I keep referring to the 70 keV. This one is the quote unquote closest looking image to what a monochromatic or single energy image would look like. In fact, if you actually put the two side by side, which I think, oh, come on. No, actually, I don't think I have that. I don't think I have that data. But if you actually compared a true 120 kV image to a 70 keV image, the 70 keV image actually would look a little less noisy and have a little less artifact. And that's why, like I said, there are some hospitals that are moving all of their imaging to dual energy here in the US. And it's just because these monochromatic images actually they can look a lot nicer. So I hope that makes a little more sense.
You mean like a mono E is just a low kV image, but monochromatic is like some cross processing and mix some stuff to get a good signal to noise ratio on that low kV.
So mono, and I may have said the word. So in all my talking, I may have said something that may have been confusing. So monoenergetic images are mathematical calculations of all of taking the low energy and high energy and blending them together. If we had the ability to image with just one energy, one monochromatic image, photon, if we had somehow the ability to only image with 40 keV photons, then that's what the image would look like. But what we're trying to do is we're mimicking that by taking a little of the low energy and a little of the high energy and mathematically calculating it. So, I mean, they'd be subtly different, but that's just how it is. So a true monochromatic image would look like each one of these images, but we don't do that. I mean, there is such things as synchrotron radiation, and we can image with that, but that's just not what we do in the clinic. It's academic. We don't even think about that. And so the closest thing we can get to monochromatic imaging is breast imaging. And that's just because we have really low energy with the different filters. So don't get too caught up on the fact that we call these monoenergetic maps. They are meant to be like a monochromatic image, but they're not actually truly monochromatic. So the distinction is purely mathematical. So let's just put it that way. It's purely mathematical.
Yeah. So the next question, I think you already answered. So the next question is, when we do the weighted average or blended processing images in the clinical procedure, what is the theory behind this kind of images? So I think you already answered.
Yeah, by blending them just gives you a little bit more of the contrast versus a less of the noise. And that's just what you see on the screen. It's just how many different monoenergetic images you can create.
Next question is about the Philips system. So does the second lower layer of the detector get any artifacts from the upper layer of the detector?
Yes, there is cross-contamination. They do put a filter in between to try to prevent that. But is it perfect that you get exactly only the low energies at the top and the high energies at the bottom? And the answer is no. Maybe I should have probably put a picture on here of a spectrum. So this is a dual source CT where the low energy spectrum and the high energy spectrum are pretty far separated. In a Philips system, they're very overlapped. And that's just simply because you're actually only using 1 kV to create the image, and you are trying to separate the two by doing some really cool physics. I have to admit, it's really neat the way they do it. And let's be honest here for a second. If I put a dual energy Siemens scanner and a dual energy image from a Philips scanner and a dual energy image of a GE scanner, and I put those 3 up, and I didn't tell you which one they were, I probably should have done this. Could you tell me the difference? Probably not. So we talked about all of the advantages and all of the disadvantages of each of the systems. And that is simply because when it comes to setting the right noise and the right dose, each system is slightly different. And who does that matter the most to? The physicist and the technologist. They're the ones that have to get the right numbers in the right place. And when they do that, then they present the images. You remember our optimization team, they present the images to the radiologist, and the radiologists say, oh, too noisy, not noisy enough, too much contrast, not noisy. And then you guys work as a team to get the right image. But when it's all said and done with, if you buy a Philips scanner versus a Siemens scanner, I think you would be perfectly happy with the dual energy. There are some differences. We talked about them. But for the mostly clinical day-to-day application, I honestly don't think you would see a big difference. So yes, there is a contamination, and yes, it does affect the true calculation of the difference between, say, iodine and calcium or iodine and water. But visually, could you probably see it? In my personal opinion, no.
So like a final product for the clinical use is the same. It's the process to get those images and make technologists happy when they use the scanner.
Yeah, and it's like I said, they each have their benefits. I mean, the dual source CT scanner really does great job with the dose. You can, we showed you in some of the slides all the way in, they're only maybe 1 or 2 millisieverts. I mean, 1.5 millisieverts. That's great. That is so low. That's about a factor of 10 lower than it was a couple of years ago. The Philips scanners and the Siemens and the GE scanners and the CAN scanners, they may not be as optimized because they don't have 2 independent tubes, but the overall image quality is still basically the same.
So the last question, I think this is very interesting. The question is, in bi-tubes, dual energy CT, only a part of the images has dual energetic information due to the small field of view of one of the 2 tubes. Do we need to pay more attention when positioning the patients than a single energy CT?
Yes, the answer is yes. So we talked about last week where do you put the patient? We should put the patient in the center of the gantry, right? The reason for that is because the bow tie filter is a very specific shape. If we put the patient in a different place in the gantry, it can enhance artifacts. It can enhance the dose to the patient, all of these things. But that said, if you want to know what the dual energy is over here in the ribs, you got to get the ribs inside that circle. So this is that one fundamental limitation. Now, that is true to this scanner. And they have changed a little bit. The newest scanner, the 3rd generation, you can do 35.6 centimeters, which may still be kind of small for a large patient. They previously were, I think, 28 or 29. The 2 systems are actually not 90 degrees. The 2 extra tubes are not actually 90 degrees. They're actually 95 degrees. They kind of opened it up just a little bit so they could make the second tube detector a little longer. But yeah, if this is the scanner you have and you need to see dual energy somewhere outside of that circle, when you go through, you put the patient on the table and you create the localizer image. So you're looking at their topogram or their scout image. It will tell you where on that image you will see dual energy. And so then you as the technologist have to know, oh, I might have to actually physically shift the patient, and so that you can get the dual energy in the right location.
And which is dose location?
It can.
Right.
It's hard to say. It's hard to say just because every patient's a different size, but it's really, when it's all said and done with, is it going to change it a lot? Probably not. It's going to change it a little, but not a lot. And if you really want that diagnostic information from dual energy, then is just a little bit extra radiation worth it? The answer is yes. Up to this point, people have been using dual energy for the last 10 plus 10, 15 years, and they always said they would justify the extra radiation dose because look at all the extra information we're getting. If that extra information is vital for the clinical answer or the clinical task, then yes, the radiation dose is worth it.
Sounds good. So which means that we need to communicate between like a technologist and a radiologist, and we should let them know that the field of view does not include the area of interest. Let's say liver cancer, and I mean based on these images, the liver we did not include the whole liver for the dual energy. So which means if the radiologist need the information from dual energy on that liver cancer, we need to move the field of view, adjust the center of the patients, and maybe increase a little bit radiation dose, but it's like a communication things that we need to do.
Yep, it is. And so, like I said, it really depends on the type of scanner you get. If you are someone that thinks dual energy is really the future, but you don't quite know how you're going to use dual energy on every one of your patients, then this scanner is probably not the best scanner to have. It might be the Philips scanner, this one, because this one you can do dual energy on every patient and you can just turn it on and off whenever you want. If you do know exactly why you're going to use dual energy, but your patient population is larger, then this might be the scanner you need. And so I'm not saying one scanner, I'm not pro Siemens, I'm not pro GE, I'm not pro Hitachi. I've never used Hitachi.
When they're neutral.
Yeah, I'm very neutral. But you have to look at the pros and cons of every scanner and look at your population, your patient population. And then you'll make the right decision.
Yep, sounds good to me. Any more questions? อาจารย์ปามีไหมคะ
No.
So thank you so much. Thank you so much, Sam. So we are looking for the next talk on the cardiac CT.
All right. Okay, pulling it up right now. Sorry, I got too many things open. Gotta find it. All right, there we go. Okay, so switching gears a little bit, we're going to talk about cardiac. And so once again, for this talk, we're going to talk image quality and then dose optimization all in one. But I'm going to, it didn't make as much sense to do image quality then dose at the end. So I'm basically going to talk about them both simultaneously throughout. All right, so let's just talk. What is the big picture? What are we trying to do, especially in cardiac CT? Well, we got a lot of motion. We have to do something we have to make our images very quick, and we have to do it in a way to freeze that cardiac motion, eliminate the artifacts that come from that motion, and we have to do so without the loss of any data. So high spatial resolution is very important because we are looking at very small coronary arteries, and they don't all go up and down. They're all going in all different tortuous angles and whatnot. And so we need high spatial resolution in all XYZ planes. We need good contrast to noise ratio. Obviously, if you're looking at plaques, that's high contrast, so you're okay. But if you're looking at regurgitation, stenosis, if you're looking at some other things, and you need to see the tissue, you're looking for, the list is really long. You need to have a good contrast from the iodine as a function of the overall physiological effect that's happening in the image. And then you'll see, well, yeah, of course you need low contrast because you're looking at both soft tissue images plus soft tissue that has contrast in it, obviously interluminary. So this is something we talked a little bit about last week, and we actually talked about it just a minute ago, about patient setup. In fact, one of the people in the audience asked this question. When we were talking about setting up the patient, should you position the patient in the center of the gantry, or when you're doing cardiac image, should you place the heart at the center of the image? And I was of the opinion that you should put the body in the center because it makes the most sense for because the bow tie filter is shaped for the body. It's not shaped for the heart. And then one of your wonderful viewers said, tell me more about Hitachi. And so I did a lot of reading about Hitachi this week. And guess what? Hitachi actually has a very specific bow tie filter meant for cardiac imaging. And so this may have been the exact same person that asked these two questions. I'm not certain, but that's very astute. And so this is something I didn't know. So I have to admit, I learned something new this week. In this example with the Hitachi, the scanner, the Hitachi scanner, it actually has that filter. And so the whole idea is actually placing the heart at the center of the field of view. And so you can use the cardiac bow tie filter plus their ability to do lateral table shift. And that gives you the ability to, in theory, optimize the spatial resolution and the radiation dose within that field of view. So you're imaging for the heart, you're going to get the best image quality in that heart field of view. You're going to get pretty good dose reduction in what I was able to read from the Hitachi papers out in the publications, is they were quoting about maybe 25% dose reduction to the heart, in that field of view. So you have to use the right filter, the right location, get the heart actually centered using either physically manually moving the patient over or using their table shift. And then you will set your actual scan field of view to be smaller, to the same size as that cardiac bow tie filter. There is a reason in this example why you would actually center the heart in the gantry, not the body. I would argue still, and once again, this is still my opinion, that for the vast majority of CT scanners and for the vast majority of patients that you will scan, the best thing to do is place the patient centered in this gantry. The nice thing about the heart, as much as it is obviously offset a little, it's actually not that far offset. The heart is still mostly central to our body. And so at most, we're only moving a couple of centimeters over if we actually physically moved the patient over. That said, if you're using a traditional body bow tie filter, it's contouring the dose and the image quality to the shape of your body. And so by putting the body centered, it's going to get you the best image quality at the center and the best dose optimization of the center and the sides. So if you're using a smaller cardiac bow tie filter and a smaller field of view, then it's going to look really good in the center, but there is the potential to have some artifacts on the rest of the body in the image. So thank you. That was a great question. It's a great comment from the viewers. Gave me a chance to learn something this last week. And so the answer is, should you set up the patient in the center or the heart in the center? I personally believe now the right answer to that question is it depends on the scanner you have. And if the scanner is optimized for a heart-centered approach, then yes, you could do that. If you do not know if your scanner can do that, obviously you can reach out and talk to the vendor of your scanner. But the safest bet is just to put the patient at the center too. Okay, so getting into really what are we going to do to image quality and dose optimize a cardiac acquisition. So a CTA as an example. We need to optimize all of these things. And that's actually quite a long list. And so when it comes to doing imaging, Tanya mentioned it's actually not that easy. In fact, probably one of the more complicated anatomical and physiological aspects of CT imaging in the body. And so we're going to go over this entire list. How do we optimize tube current, tube voltage, scan time, the rotation speed, pitch, the type of way, the way we imaged? Are we going to do prospective imaging versus retrospective? And I'm sure most of you know what that means, but we'll define what those are. The type of ways, are we going to do helical versus axial or, step and shoot sequential imaging? How are we going to, the field of view, the beam collimation, the filter size, all of these things, we're going to talk about them. Reconstruction size, types, iterative reconstruction versus deep learning now. I have some images of deep learning in the heart. And then, of course, slice thickness and all that kind of stuff. So let's just go through this step by step because there's a lot of there's a lot of ways to look at this. And actually, when we break it down, it can actually be fairly simple at each step. So what is the right MA to use? Well, that actually has a lot more to do with what are you trying to image. As we mentioned, if you're doing calcium scoring, these types of images have become the new type of routine clinical image, much like lung imaging and mammo screening. More and more centers, more and more hospitals are doing routine calcium scoring tests. Now, I'm not a radiologist, and I can look at that, and obviously I know where to put my ROI, and I know how to do my calculations based off of that plaque that I can see here. And so you don't need a lot of photons to get that image right there. And therefore, obviously, you're not injecting iodine in the image. And so you can optimize the MA depending on the clinical task. Whereas if you're doing a nice CTA, you want it relatively noise-free because you want to be able to see the finest structure, obviously not seen in this, but if you're looking at the LDA or any one of the coronary arteries, you do need to see that structure. And if it's too noisy, it's hard to see that. So we do tend to use a higher MA for these more complex CTAs. So, and we're going to talk a little bit about the tube modulation and the tube current modulation and other ways to optimize the MA when we get to another stage in the optimization process. Which KV do we use? Well, older systems, if you have an older system, you're basically limited to 120 kV. So there's not much to optimize there. But for those of those systems that have more power, and they have a larger generator, then you can typically use a lower KV, or if your patient's smaller, so you just don't need as much energy power, you can do more of your patients at lower KV. So a couple of things. Remember, we talked about this last week. KV, the radiation dose changes by the square of KV. So therefore, going from 120 to 100 KV reduces the patient dose. But just like, quote unquote, those monoenergetic images we were looking at a minute ago, when you shift towards lower energies, the intensity of the attenuation, because you're using more photoelectric effect, the intensity of the attenuation in these images is much greater. Therefore, the contrast is inherently much greater. And so you can get nice, clean images at these at the lower KVs. And so just the contrast really just steps out, just kind of pops. And here you can see this is a 70 kV image compared to an 80, 90, 100, and 120 kV image. And so tube current, when there was a publication that came out and they asked this question, so it's almost 10 years ago, they asked the question, if I use a lower KV, would the image quality and the diagnostic task be affected? So when the radiologists looked at it, they had a 0 to 5 scale, and they were able to rate the quality of all of these images. And they did it as a function of KV. And here you can see it's basically the same. In almost all cases, the radiologist said the image quality was sufficient at 100 kV. And therefore, we can go from, say, 120, which is going to be a little less contrasty, to 100 kV. And there was no effect in the overall ability to do the diagnostic test. It just actually looked a little better. That said, the radiation dose was statistically significant. In other words, the radiation dose did decrease at the 100 kV than the 120. So optimizing using lower kV wherein possible gives you better inherent contrast and noise in the image and less radiation dose to the patient. Okay, so let's talk, for example, speed. This is obviously the hardest thing to do. When you are imaging a moving target, you have to move faster than that target, or it's just, you will have motion blur. It's simple. So when you look at, here in the US, we have the, what is it called? The North American Society of Cardiovascular Imaging, or the NASCI. They basically say the target heart rate for, say, a coronary CT exam is about 60 beats per minute. If the heart rate is much higher, that's when they say it's probably okay to use beta blockers to try to chemically reduce the heart rate to get it to a manageable or reasonable rate so that we can image with a CT scanner. physiologically speaking, normal resting heart rates are somewhere in the, if you're nice and healthy and everything's going well, you're in the 70 to 80 range. Obviously, it can get up to 100, and it's just normal. There's a lot of fluctuation. Just normal physiological spread. Let's talk about what can we do for the CT scanner. Well, most scanners right now, the fastest scanners out on the market are about a full rotation time can go about, it takes about a 0.25 seconds or a quarter of a second to go all the way around. If you're imaging with a system that can go about 0.25 seconds, you are able to image a 70 beats per minute heart without motion. You can freeze the motion. That's a good thing. Now, if you want to image that same patient that comes in and their heart's racing at 100 beats per minute, well, your rotation time would actually have to be about 0.15 seconds. And there is not a CT scanner on the market that can do that. And then if you want perfect, ideal, completely motion-free, crisp, clean margins, you actually need to be imaging at roughly approximately 50 milliseconds, which is just not even possible. So it's 0.05. And that's not even close. If we can do 0.25, 0.05 is not even close. So most scanners can't do this. Some scanners can at least do 0.25. Now, that doesn't even approach the fact that we have little kids, that look neonates with really high heart rates. You have people that are just sick or stressed out because they're freaked out about getting a CT scan and their hearts are just racing. So let's talk about how we can approach different ways to image the heart. Obviously, we can give them beta blockers. We can chemically just lower it. So that is always the option. That is hopefully an option. If it's not an option, there are still ways that we can image the heart, a fast moving heart. So let's talk a little bit about the other aspects going on. So we know there's the cardiac cycle, and that takes somewhere around the 0.6, about a half a second to a second to go all the way from systolic to diastolic in the heartbeat. Obviously, every heart rate, every human has irregularities. We're not perfect heart rate or heartbeats. There are always going to be times when we might have an arrhythmia, where there's just that, where something along the diastolic to systolic spectrum, something just changes, we skip a beat or something happens and something's just not right. So these are the three things we need to optimize. Obviously, the amount, the rate, the beats per minute. Then we need to image within the cycle so that we know diastolic to systolic, or I should say systolic to diastolic. We need to image within that range. And then we need to be able to take into account when the heart doesn't actually do the same rate over and over and over and over again, where it skips a beat, where it has an arrhythmia or something. We need to be able to account for those three things. Okay, so in a perfect world, we'd just stop the heart and then we'd image it and then we'd turn it back on and keep going. Can't do that. We can ask our patients to hold their breath for a couple of seconds. We can't ask them to stop their heart for a couple of seconds. But we do have a heart that does naturally stop itself for just a split second. And it's in the systolic phase, of course. So we go systolic to diastolic. There's going to be that moment where it actually has low cardiac motion. And so people have gone out and they've measured this. And depending on your heart rate, how fast your heart's beating along the x-axis right here, tells you how long the heart will be in a diastolic phase. So for low normal resting heart rates, maybe the 70 and 80 range, you're spending about a half a second in diastolic phase. Unfortunately, when you get a little more, your heart starts racing or you're just unhealthy and your heart rate's already up this high, to image in the diastolic phase where there's minimal low cardiac motion, your window, your time frame decreases substantially, going from 500 down to 200 milliseconds or even lower. So imaging a fast moving heart only gets harder because we have a much smaller target to hit if we're trying to image in the diastolic phase. Sorry, there we go. So what we're going to do is we need to be able to image that. And so then the question is, how do we image that? Because we have two options. We can do pitch or we can do axial imaging. So the vast majority of CT scanners are able to do pitch. In other words, they do helical imaging. And so we have to take into account the type of pitch, how much the table will spin, how much the CT scanner will spin as a function of how fast the table will move the patient through the scanner. So to cover the heart, we need, say roughly 15 centimeters, 150 millimeters. That's just an average size heart. Nothing, no cardiomegaly, just a normal average, craniocaudal or, superior to inferior dimension of a heart. So if that's the case, then we need to be able to image the heart in a way that we sample the heart as it goes through all of its beats. And so if we just simply go straight down through it as fast as we can, we're not actually going to image the heart perfectly stationary. It's going to be compressing. It's going to be going from systolic to diastolic. So we actually go the opposite route. We go as slow as we can when we do helical imaging. We do very low pitch, 0.2 to 0.4. So it's sitting there spinning as the heart is beating, and it's able to then sample the heart all the way through its full cycle, systolic to diastolic, one heartbeat. It's able to cover that as it then goes over the entire heart rate, over the whole physical aspect of the heart. So it's important to know that we can obviously, the way we reconstruct that and when the X-ray tube is on as it's beating through that, we'll talk about in a second. But if you're setting the MA such that the system will change the MA, the tube current modulation, as it spins around the body, because obviously we're imaging the heart here, but that's going to be passing through a larger, wider aspect of our bodies laterally versus anterior to posterior. So if we do tube current modulation, then remember, dose and pitch are separated. You can have low pitch and high pitch, and you can have the same dose output. But if you're using a fixed tube current, which some people still do when it comes to imaging the heart, then, there we go. If you go really low if you go really low pitch, the dose is going to go up. Obviously, as you're sitting there spinning, if you're going to cover the same part of the body 2 or 3 times before it moves a little deeper into the body, into the scanner, obviously the dose goes up. That is only true if you're using a fixed tube current. So the ideal case here is if you're going to be able to cover the image, if you're able to image the heart with an axial single spin, if the scanner itself can do 16 centimeters, 160 millimeter coverage, that's wonderful. But for the most part, most scanners out there are limited in their overall coverage. Therefore, they're going to use they're going to use helical imaging, and therefore they need to use really short or really small pitches so that we can really sample the heart. And the way we're going to do this is we're going to try to image in that diastolic phase where there's little motion. You can kind of see in the overall heart rate, and you can see the trace of this EKG. You can see there's a lot of motion, in the systolic side, but when you get to the diastolic, it's pretty quiescent, relatively little motion. And so we want to acquire as much information, use that phase of the heart to acquire as much of the image data as we can. If you have a sufficiently fast scanner, you might be able to acquire all of your information in one spin in this phase right here. Remember, all we need is 180 degrees plus a little bit more called fan angle. The 180 degrees plus fan angle. If you have that much data, you can reconstruct the image. You don't need a true 360 degree rotation in the heart. And so one way to help speed up the image acquisition is we don't actually acquire the full rotation worth of data. Now, if you cannot spin that fast, then like I said, sometimes you have to spin over that same part of the body 2 or 3 times. But we don't want to do, what we can do is we can simply turn the scanner on and off at that exact same location, and we just do it multiple times, 2, 3, 4 times, however we need to collect enough of that data to get that 180 degrees plus fan angle. So it's not necessarily that we're just going to sit and scan and scan and scan and scan and overexpose the patient. But if we use what's called prospective EKG gating, we hook up the patient, set up the EKG. So we're collecting the heart rate, the trace of the heartbeat. We can then tell the system, the computer, the CT scanner can then see that trace and know when to turn on and off and on and off the scanner to collect the information it needs, but to do it without overexposing the patient. So this is what we call prospective EKG gating, where you turn on the CT scanner only at a certain location along the heart rate, along the heartbeat. There are 2 ways to look at this. There's what's called a fixed time approach, where when it catches, so on the typical QRS spectrum, when you're looking at this heartbeat, when it goes from the peak, which is the R, once the CT scanner sees the R peak, it knows to immediately turn on the CT scanner at a fixed time after that R peak. And it will always turn it on, irrespective of what's happening right here. If for whatever reason the heart rate races and it goes a little quicker and that the second R peak gets compressed, or if there's an arrhythmia or something, if you're using a fixed time, typically the system will always turn it on and it'll always acquire it right then. And so it can potentially maybe miss that dystolic phase. The other way to do this is what's called percent delay, where now instead of saying, okay, go a quarter of a millisecond after or a half a millisecond after, it's going to do a percentage of the time. And so in this case, what happens if we want to image when the system sees the R peak, we can tell it to go, say, 60%. So it knows the time from R to R because they're measuring it. It's measuring the heart rate throughout before the CT scanner ever turns on. So it knows what an average R to R interval time is. And so if you say, I want you to go at the 75th percent of that, or the 60th percent, or whatever it is, it knows what it is. And so when it sees the R peak, it counts down the time and it will acquire that. Now, it should be said that in both cases, it knows what the R to R peak is basically because it's been tracking that, it's been measuring that. Every so often, the body will throw out, obviously we'll have an arrhythmia or something goes on. And the system needs to be able to recognize there's a divergence of the R to R. And so if it's going along and it knows the R to R peak is whatever that time is, but then all of a sudden it measures something that's a little different. Well, it's going to stop. It's not going to acquire any images until the R to R peak gets back to its normal average. And then it'll start acquiring data again. And that's just their way of making sure that it's more accurate at collecting the data at that specific dystolic phase that you've asked it to. And so it's a good way to keep the radiation dose to the patient low, because if you're acquiring a bunch of images and you have arrhythmias or other issues, and there's a lot of motion in the heart, well, when you go to reconstruct the image, it might not look good enough. You might have to do the exam again. So usually we set it up so we're doing the percentage time, the percent of the R to R interval. Where do we typically want to image? Well, traditionally, people say 70% or 75%. So let's look at that for a second. In this example, coming out of Johns Hopkins, it's a university hospital here in the US. If you look at the systolic phase over here, the QRS and T complex, after a certain percentage of time, if you go about 70%, that is basically dystolic. If we hit it right and the heart rate is consistent and it's good, well, the motion is going to be not as blurred. And you can see here, looking at this coronary artery, it looks nice and crisp. The edges are well defined, nice and conspicuous. And so this is what you're trying to get, a nice, clean, solid image. Now, if you imaged for whatever reason over here, say 20, 30%, or for whatever reason it acquired right at the QRS peaks, then you would see this blurred out. The artery, the vein, excuse me, the artery would be completely blurred out. So there was a publication that came out. It's a little over, it's been 11 years now. And basically what they did is they took and they acquired a bunch of images, and I'll explain what a retrospective is in a minute, but basically they acquired the image across all of the percentages, across the entire heart rate, the heartbeat, excuse me. And then they looked at and they reconstructed the images at each one of those percentages, and they showed them to the radiologist and cardiologist, and they said, tell me, how does, I want you to look at the RCA, you know, the right coronary artery, the left main LM, the left anterior descending with the LAD and the circumflex of CX. Tell me, how do these arteries, do they look? Just tell me the sharpness. Do these coronary arteries look good? Can you make your diagnosis? And basically what they said was for low heart rates, anything, and they defined a low heart rate as anything less than 70. They said that the numbers came out, excuse me. Sorry about that. If the heart rate was less than 70 beats per minute, then they liked the image quality that came out at the 65 to 70% interval. And if the patient had a higher heart rate, anything over 70, then they actually preferred a 35 to 45%, somewhere in that range. Here's an example. This patient had a heart rate over 70 beats per minute. When they reconstructed at the 60% interval, you can see the artery doesn't look as good. The motion is blurred out. But if you imaged it at the 40%, it's a lot more crisp and it's a lot more defined. In another paper, and this was in 2008, so once again, still about 11, 12 years ago, they looked at they did the same thing. They looked at all the percentage intervals, and here I'm giving you a histogram, where if the heart rate was greater than 65, slightly different than the previous publication, they said the best visualization of the coronary arteries was basically at the 50th percentile. We're somewhere in that range of 40 to 50% interval. But if it's a slower, more manageable heart rate, then almost always they were very happy with the 75 percentile. So somewhere in that, 70 to 80 percentile. So obviously these two papers came out, and both of those papers had slightly different results, but they were basically grouped around this idea. High heart rates, you were actually going to be wanting to image somewhere down in the interval of 40 to 50, and low heart rates or manageable heart rates were upwards of the 70, 75 percentile. So if we're doing prospective EKG gating, we're going to just acquire the image every time at that percentage, wherever it is along the systolic to diastolic phase. And we're going to and we're going to go zero dose, and all of a sudden we're going to turn on the system, ramp it up, and collect all the data we can at that phase. Now, because life is not always perfect, realistically, instead of acquiring it exactly at that phase, that percent phase, we're going to acquire a slight padding. We're going to just actually increase it a little bit. So instead of exactly at, say, 45, maybe we'll do 40 to 50 or 35 to 50, something to that effect, so that we have the opportunity to collect that data. And if we reconstructed at the 35 and it's still a little too motion, 40, still a little motion, 45 is good, then okay, we got it. We got the data we needed. We did acquire just a little bit longer, but it was worth it because we were able to get the right amount of data, and we didn't know exactly when we needed to collect it. So doing this padding, though it does increase the dose of hair, it does increase the amount of data that you collect, it gives you a lot more freedom to reconstruct the data. So what are some of the limitations of prospective gating? Well, obviously, we're only collecting the data or taking a picture of the heart at one location on the heartbeat or the systolic to diastolic spectrum. And this kind of expects the heart rate to be consistent, obviously no arrhythmias, and we really do need slower hearts. And so if it's not well behaved, then the system is going to take a lot longer to acquire the image, because like I said, if it knows what the traditional R to R peak time is, and every so often you get an arrhythmia and it's a little lower or longer or whatever, the system is just going to keep spinning. It's not acquiring data. It's just going to sit there. The patient's going to be waiting as it collects, as it's waiting for the peak to get back to its right timing average to start acquiring the data again. And so in the total exam time can be longer with prospective EKG. Obviously, the strengths are we're not wasting radiation dose on collecting data where there would be motion. So the patient dosing is generally at the lowest in prospective imaging. What about retrospective imaging? Retrospective imaging, as I've alluded to, is basically when you turn on the scanner and you acquire the images over the entire, R to R peak spectrum, or in many cases, we'll do it over multiple heartbeats so that we get a good average. Now, there is a way where we can try to minimize. This is obviously the greatest amount of dose, right? So it's just turned on, it's on all the time. But one way we can collect this data, there we go. One way to collect this data and be as dose conscious as possible is we're still going to try to collect most of our data only over the diastolic phase. And depending on the heart rate, it might be more skewed towards 70% versus maybe 40%. But we're going to have it turned low for it. The system will stay on at all phases, but it will only ramp up at specific phases. And so you still have to be plugged into an EKG system, and it's still tracking that R to R peak. And it's going to still collect all this data. And irrespective if you do a full dose retrospective scan or a retrospective scan that's at some percent dose reduction, you can, because you have data at every phase, you can still go back and calculate or reconstruct the images at 10%, 20%, 30%, 40%, or any kind of mixture of that. Obviously, if you're doing this retrospective scanning one, if you reconstruct an image at say 10%, if for whatever reason, the image quality is going to be a lot lower because it's just going to be much more noisy. All right, so is there a difference if we're acquiring the data using a helical low pitch versus a sequential single spin? And in the olden days, or traditionally, if you still have 4 centimeter coverage, so 64 slice scanners, when you looked at the difference between when you look at the image quality, acquiring the image both in helical versus sequential images, or these axial step and shoot acquisitions, the image quality was basically the same. The doctors could still do what they needed to. The physicians had the data they needed for the diagnosis. But the dose in the olden days when you did sequential was lower because it was step and shoot. And you remember we talked about the helical overranging, and if you're going to be constantly imaging and you're having a low pitch, you're going to be overlapping the dose, the anatomy multiple times to collect all the data you need to create all of the images. And so there can be at times 40 to 60% overranging effect. The overall dose is just that much higher. You can just see sequential acquisitions 4 to 6 millisieverts versus 12 to 15 millisieverts. And this is a study, it's a little older now. So I would probably say these numbers will come down just a little bit just by nature of having more efficient, higher, greater technology-based scanners. But when it looks, if you still have the limitation of just a 4 centimeter scanner, then doing that step and shoot is going to be by way of dose still probably one of your better options. But once again, that's just if you still have those older scanners. Many may still do. If you've moved towards at least one scanner in your hospital that is these new dual source, or as we've talked about, the single 16 centimeter, those wide beam cone angle CT scanners, then it's probably best to move most of your cardiac imaging to these newer scanners, because as we'll explain going forward, they can produce a really high quality image at a really low dose. You can still get good high quality images with the smaller field of view, the 64 slice scanners. You're just limited in how fast you can acquire the image and the radiation dose. to the limit to which you can reduce the dose. So let's talk about what the more modern day, probably the more advanced CT scanners. So in this case, we have a dual source CT scanner, originally developed for dual energy. But if I turn tube A on to 1 kV, let's say 120, and tube B to the same kV, well, now I'm still doing single energy. I'm not doing dual energy, but the CT scanner doesn't have to cover the same heart. It doesn't need to go all the way on around to 180 degrees. Because by the time tube A rotates over here to the location where tube B is now down here. So between the data we collect from tube A and tube B, we actually only have to spin half the time. So tube A only has to go 90 degrees and tube B only has to go 90 degrees. So if you are imaging at a 0.25 millisecond rotation, that's as fast as it takes to go all the way around, but you only have to go a quarter of that distance, so half for tube A and half for tube B, well, then you are actually able to image a heart that is somewhere in that 63 millisecond range. And so this is one of those beautiful benefits of having these this dual source CT scanner is you can go fast and cover as much data at a really high heart rate. Now, once again, just remember, because the B side tube has a smaller detector, you will have a limited field of view to image the heart with, even though it's not dual energy, it's just that fact that you are still limited to 38 centimeters in the third generation dual source CT scanner, or somewhere around 29 to 30 centimeters if it's the first or second generation. Now, this is that example where if you do your image and the heart is not in the circle, in that yellow circle, you might actually have to physically move the patient to get that heart centered in there. Okay, so we obviously just discussed how we can get really fast temporal imaging with these dual source CT scanners. Now, most of these scanners, the newest one does have actually a pretty wide detector, but most of them are still narrow detectors. Therefore, all of the dual source CT scanners are still usually acquired in helical acquisition. In a traditional case, if you have this dystolic region right here that we're going to acquire all of our images in, to collect all the data in that part, you might have to pass over it 2 or 3 times as you collect multiple helical runs. So the heart is there, the body's moving, it's going to acquire, it's going to acquire, it's going to acquire. And then what you've done is you've collected all that data, and that phase of the dystolic, you're good. The exam is done. With the newest scanner, they have what's called the turbo. What's it called? Turbo. I can't remember it. I'm drawing a blank on it. Turbo flash, where the system, because the scanner table can move real fast, and you're using 2 tubes at the same kV, you can actually acquire all the data over that whole, let's say, 60 to 80% on your dystolic phase. You can acquire that all in just one pass because you're moving fast enough. Your detector might not be wide enough to collect all the data, but you're pushing the table through fast enough. And so if you can't collect it all in a single rotation, the only other option is to move that table faster. And this system is really good at that. The only issue, though, is if you throw in arrhythmia, the system might pass the patient through, but it might not actually acquire the data and has to stop, back up, and start over again. But that's a minor limitation, I think. So when they looked at this in 2015, once these new dual source scanners came out, once again, image quality was always the same, but the radiation dose was much lower, being able to acquire these really high pitch acquisitions compared to the step and shoot axial imaging for the 4 centimeter coverage. So we already said 4 centimeter coverage, axial step and shoot was better on the older scanners than the helical. Now we're saying that high pitch is even better than that. So as you can kind of see, as we're moving forward, 2008, 2009, doses were higher. Now 2015, the doses are coming much lower. I think you're going to see that progression as we keep stepping through. that as we get farther and farther along in time, the technology is helping us get the doses much, much lower in the cardiac imaging. So once again, the goal here is to get the whole heart. So we're talking about a 15 centimeter heart. So the 64 slice scanner, it at best is 4 centimeters. So, just pictorially here, we're only able to ever image a certain part of the heart and of course the artery at any one rotation. So therefore we obviously have to use helical pitch to collect that and collect it as we increment and step down through the body. Now, if you have that wide angle 16 centimeter 320 slice CT scanner, for the most part, you can get pretty much all the heart in a single rotation. Therefore, it's a one rotation. You've collected all the data at that heartbeat, at that percentage of the phase, and you've got it and you can move on. This does require it's probably the fastest way you can acquire the data. And so it does require less patient motion. It produces an image with less patient motion. It can require less contrast because once you've injected the dose, the IV bolus, the IV dose, once it gets to the heart at that right timing, you acquire the image, and in a snap of your finger, you're done. And so the exams can be really quick. And the biggest caveat to this, and probably the disadvantage of this, is because you're done in a single rotation, 0.25, 0.275 seconds, and you're done. You got to make sure your contrast bolus timing is right on. If you miss it, you might actually acquire it before, or you might, well, probably not after, but if you acquire it before, then obviously the image is going to look very diluted. So not all of these, depending on how fast that scanner can go, or how fast your heart rate is, and the diastolic phase might be truncated slightly. If that's the case, then you might still need to acquire the multiple spins to add up all the data at that particular diastolic phase. And so if you look at the Canon GE scanner, those are the two wide cone angle scanners on the market. They can spin as fast as 0.275 milliseconds currently. And the GE scanner has said that at some point in the near future, it will be able to go 200 milliseconds or 0.2 seconds. That's pretty darn fast. But let's take the numbers as they are now at 275. If you, once again, you really only need about 1/2 plus fan angle. So in this case, you can image at 137 milliseconds. That's reasonable. That's respectable. If you do 2 spins, so you have to image over 2 heartbeats, now 275 single rotation twice at that specific diastolic phase, you're down at 69 milliseconds. So these wide angle and the high turbo flash, the high pitch dual source CT scanners can basically image the heart at the exact same, with the exact same speed. One just has to do it twice. The other one just has to go real fast. So when you look at the way we reconstruct these images, iterative reconstruction, which helps to reduce the amount of noise in the image, iterative image quality wise, there was no difference. Dose, if you reduce the amount of MA you use and then use the iterative reconstruction to clean up that noise, so iterative reconstruction compared to filter back projection, you can still get you can get pretty substantial dose reduction using those new reconstruction algorithms. And I would argue iterative reconstruction is pretty standard now. So it's not that paper, which came out a few years ago, is probably a little out of date. But even more so now, when we compare iterative reconstruction with deep learning, this is just one of our patients. He's got a univentricular or a Fontan patient. So we got one ventricle. And so that's why the actual IV contrast is rather diluted in this image. But the image quality itself is fairly noise-free. Here's another patient with a standard cardiac anatomy. Once again, iterative reconstruction. This is a larger patient, so you got a little bit more noise throughout the soft tissue, noise overlaying in the heart. And in this case, with the deep learning, that noise is basically gone. Now, the other nice thing, and this is specific to the 2 vendors that we have, which is GE and Canon. If you look at the sharpness of the image, they not only try to clean up the noise, but they're also trying to enhance the structure, and they're trying to make the spatial resolution much more finer. So I would argue the bone structure is a little tighter, a little more edgy. And so that would be the same for the arteries and whatnots. If I actually had a close-up image of the heart, you would probably be able to see the coronary arteries, and the edges would be a little bit more enhanced, a little more distinct. So so those are just the images. Now let's look at what are the doses that we're typically dealing with now, comparing prospective EKG, which tends to be the lower dose approach. So if you're doing a single spin, 320 slice scanners, you're somewhere in the 0.6 to 1.7 millisievert range. So that's pretty respectable. It's not that much more than a normal body acquisition. High pitch dual source CT scanners, they're somewhere in the 0.5 to 4 millisieverts. Now, obviously there's a range because that's just, you're looking at multiple institutions, multiple hospitals and how they do it. The fact that it can be as low as 0.4 demonstrates that the system itself, technologically, when optimized right, is a very robust low dose acquisition technique. And then when you look at the conventional scanners, your quote unquote 64 slice scanners that are limited in their approach, even when you use iterative reconstruction to help clean up the noise, so therefore you can reduce the MA, these systems are always going to be they're older technology, so they're going to be higher radiation dose. So about 1.5 to 3.5 millisieverts. So the values of the radiation dose, what you will see in Thailand, are going to vary from site to site, institution to institution, and more specifically, technology to technology. So looking at the data that Dr. Panayottai developed, of course, they have some coronary CTA exams, and they looked at prospective versus retrospective. And looking at these values, you can see national diagnostic reference levels are set for the prospective, roughly just shy of 19 milligray, and for the coronary CTAs in retrospective, a little over 60, compared to your fellow compadres in Japan and Korea, and they only have just one value for the two. The US over here in the West really don't have any values. In the US, we have values that are set slightly differently. They set what are called dose notification thresholds, in which case these are not necessarily diagnostic reference levels. These are values that a lot of, for example, the ACR and a few other institutions, or I should say societies, what they basically said is if you ever have a retrospective study that exceeds 150 milligray, then that's probably too high, and you should do a root cause analysis to review what went wrong. And for prospective, it's roughly 50. So these are just values where you would set on your dose monitoring software to just determine if it's too high or too low. The acquisition, not too low, but the acquisition of that particular patient, how it compares. So it's not a diagnostic reference level, but it's an internal hospital value. And you can just see how they are much higher than the diagnostic reference levels that Thailand has. So kudos to Thailand. These values are great. These are probably respectively low. And so you can use these to just look at the overall values you have at your hospital and determine, if it's above this value, either of these values, then the question is the image quality necessary for the clinical task, or can we reduce the radiation dose but still maintain the same clinical outcome? So what are the overall, so kind of summarize it. Let's put some of this, these are all a bunch of pieces. Let's start putting some of this together. So what we're going to do is steps to optimize cardiac CT. We want to minimize the scan range. We want to do our best to image a heart that has a reasonable rate of beats per minute. If you can't do it because your scanner isn't quite fast enough, we've talked about the newer scanners, the dual source or the single spin with the wide beam width. Those systems, you do kind of need to use, your patient population probably uses a lot more beta blockers. The best way to get the best dose optimization possible is using the EKG tube current modulation. And we talked about using the lowest kV possible, as long as the system has can produce the right MA to keep your noise down. And the lower KV gives you obviously dose reduction, but it also gives you a good contrast enhancement, a little bit more of a pop to the image. And then depending on how you image, what's the clinical task? If it's something such as inherently high contrast imaging, such as calcium scoring, then really you can enhance your dose reduction even more by reducing your MA manually, because you just don't need a lot to do calcium scoring. Now, depending on the type of scanning that you do, there may be reasons why you would do a retrospective study. Maybe the heart is just so fast and you just don't feel comfortable doing prospective EKG, or you do want to see the heart as it is at all phases of its heartbeat. But for those of you that are doing, for the most part, prospective EKG triggering, if you use sequential scanning for the older systems, the 64 slice scanners, that's going to be a lower dose than the really low pitch helical. And then if you can do it with the wider beam width ones, well, that's great too, because it's usually one or maybe two spins and you got all the data you want. You can, of course, use the newest model scanners with the turbo flash, where you go really fast through the scanner and you're using the same KV on both X-ray tubes. So I probably should have added that also there too. So high pitch imaging, if not high pitch, then you're probably still doing axial or sequential imaging for the heart. Then use iterative reconstruction to further reduce your MA. And that's just with all of the scanning. I almost assume that's standard. I probably should just take that off, because if you're not doing iterative reconstruction, either your CT scanner doesn't allow that, because you just have an older scanner and you're stuck doing filter back rejection, or you just haven't turned that on. That said, I will be the first to admit, when you use iterative reconstruction, it does fundamentally change the type of image, the texture, of course, and it can soften the edges in the image. I showed you this last week. So there may even be some doctors out there that just can't look at an iterative reconstructed image in the heart and feel that that's appropriate, because it either softened the image a little too much or whatnot. So these are probably the kind of the higher level steps to optimizing the image. And it really does come down to, kind of, as I would say, even higher level. It really just depends on the technology that you have. But that said, even the older scanners, 5, 10, 15 years, well, not 15, but 5, 10 years old, you can still acquire a really good cardiac image. Your dose will probably just be a little higher. All right, that's all I have for you.
Thank you so much, Sam, for the comprehensive reviews for the cardiac CTA. And อาจารย์ปานคะ Do you have it?
ของประเทศไทยที่ดูแล้วมันต่ำเนี่ย เพราะว่าโรงพยาบาลที่มีจำนวนเคสพอจะเก็บมาให้20 รายเนี่ยค่อนข้างน้อยนะคะแล้วก็อันที่เป็น prospective เนี่ยแล้วมันต่ำมากเพราะว่ามีโรงที่เก็บมาให้เท่าที่จำได้นะคะมี5 แห่งเพราะฉะนั้นมันก็อาจจะไม่มันเป็นได้แค่ local DRL แล้วก็เครื่องมือเป็น high end หมดเลยคิดว่าน่าจะมีสัก2 ที่มี turbo flash เพราะฉะนั้นมันก็เลยค่อนข้างเอฟเฟกต์ค่อนข้างเยอะเวลาที่จะไปใช้จริงๆคงไม่ใช่เป็น national DRL ประมาณนั้นค่ะคืออย่าเอาไปใช้ว่าต้องไม่เกินเท่านั้นเท่านี้แต่ถ้าดูอันที่เป็น retrospective และเทียบกับของญี่ปุ่นจะเห็นว่าตัวเลขมันจะเท่ากันนะคะอันนั้นก็คงใช้ได้แต่ prospective เนี่ยคงเป็นได้เฉพาะบางที่แล้วก็ถ้าใครจะเริ่ม prospective อย่าไป fix กับตัวเลขที่เห็นว่ามัน 18.7 หรืออะไรแบบนั้นเพราะว่าการที่ทำ prospective หลายคนอาจารย์หลายคนคือเขาเฝ้าเอง เขาเขาเข้าไปอยู่ตรงนั้นด้วยหรือไปอยู่หน้างานด้วยนะคะพอ prospective dose ก็เลยจะลงมาต่ำได้เยอะส่วนใหญ่แล้วจะ comfortable อยู่ที่ retrospective แต่ก็อยากให้เชียร์ว่าที่ไหนพอทำ prospective ได้ก็ค่อยๆขยับเข้ามาอย่ายึดตัวเลขนี้เป็นหลักให้รู้แค่ว่ามันน่าจะลดได้เราลดได้เท่าไหร่ก็ดีกว่าไม่ลดเลยนะคะจะลดลงมาแล้วเป็นแค่สัก30ก็ยังดีอย่างเงี้ยอยากให้ใช้มันแบบนั้นมากกว่าเพราะมันอย่างที่แซมก็จะพูดบ่อยๆมันไม่ใช่ right or wrong มันไม่ใช่ได้ตกมันไม่ใช่อะไรล่ะคะคือดีหรือไม่ดีอะไรอย่างเงี้ยมากกว่า
You are so good. You know what are we talking about because you show the slides that we have the data.
I think I'm learning Thai, but I probably just heard DRL.
So that's good. So Dr. Paruthai just mentioned that the number probably we have like a very small small sample size. So which means it's probably not like the real national DRL, but it's maybe local DRL, but it's a good step to start. At least we have some data collections, and she talked about some limitation that for the prospective getting study, the number is low. Maybe because we have like a high-end technology, and also the radiologist monitor the patients by themselves, almost every patient, and this is in the academic hospital. So which means we are very careful on the image quality and radiation dose. So, but at least it's like a first step for us to watch and to learn the process. So we still need more data.
Yeah, that's true.
I think that when starting prospective, do not I have to come to about 20 or 18. Because from 60, if you can go down like a 30, that is great enough.
Yeah.
So don't use this as the target.
Yeah, and that's very true because ultimately, wherever you are, high or low, you need to look at your image quality as was just said, and then you obviously need to ask the question: am I getting the right diagnostic information? And so there, at times, there is a reason to go a little high. Some of these patients, if they have a high heart rate, you may need to open up the padding. So even though you're doing prospective, you're actually acquiring more of the dystolic phase so that you can then look at maybe, 3 or 4 percentage, 3 or 4 values on that percentage. And so yes, there is a reason why the dose can be high. But even though, yes, this might be a small percentage from a few academic centers more locally, I still think it's really impressive because most places, in the European and Australia and around the world, most places haven't quite figured this out either. So CTAs are not you don't do as many cardiac CTAs as you do abdomen pelvis. So you'll never have a lot of data. But collecting what you have, and that's a great starting point. So I think that's just kudos to you guys for collecting this data.
And I think one thing is the key is like a patient preparations to get the right heart rate, to get the good image quality. So that's why nurse can get involved and help us to prepare the patients.
Yeah. Yep. In pediatrics, obviously, there's a lot of just trying to keep the patient calm. The pediatric patient will usually always meet with their referring physician first, and they will talk to them and they assess how likely, they obviously can do them EKG and they can measure the heart rate, but then they can also measure, the likelihood of that patient being nervous, which would increase the heart rate, or if they can work with the patient to keep the patient's heart rate naturally lower or closer to baseline, then it helps us limit how many beta blockers we need to actually use in our patient population. So yeah, it's a big team effort. It's not always, but some centers, especially in adult hospitals where it's just, you don't have time to mess with that, then you just prescribe the beta blocker for every patient and every patient gets a beta blocker. And then irrespective of the technology, you should be able to image the heart at the right systolic phase.
So thank you so much, I think we don't have any more questions this time.
Yeah, cardiac CTAs, a lot of them have been very well developed. And so most scanners, when you buy the scanner, it has some good CTA packages on it. But for whatever reason, if you don't, like I said, lowering your KV, using EKG tube current modulation, those are great ways to get the doses lower. And then obviously, as Dr. Panyatai mentioned, having doctors there observing, that's pretty common. Radiologists working closely with cardiologists actually at the scanner. And those are really great ways to keep your doses down too. And then using the best technology you have at the time. So obviously using iterative reconstruction, if you have deep learning, that's another great way to reduce your doses. And then getting the faster scanners. It's just the faster you go, the better the image quality. It just always will be. And so less repeats.
Sure. So thank you so much, Sam, for give us an excellent lectures as always. And I will give you 2 weeks spring break and we will come back. I give you 2 weeks spring break. So, and we will come back again for the next modality that we are going to talk about, interventional radiology and also fluoroscopy. And after that, we're going to talk about the DR and CR and also mammogram. So it's going to be how many weeks? 7 weeks, I think. Yeah, 7 more weeks to go to finish the whole course.
All right. Well, happy holidays to everyone in Thailand. I will take this opportunity to throw water on all my friends here in the US.
So yeah, because you're gonna have 2 weeks break. 1 week is for like a family visit, and second week is water festival. Yeah.
Yep, I love it.
Okay. Yeah. So ก็สำหรับทุกท่านนะคะเหมือนเดิมนะคะทำประเมินนะคะแล้วก็ส่งใบประเมินภายในวันพฤหัสตอนเที่ยงคืนเพื่อที่วันศุกร์จะได้รับไอ้ CME Certificate นะคะแล้วก็เราจะหยุด2 อาทิตย์นะคะให้ไปเชงเม้งไปพบปะญาติกลับบ้านนะคะไปเล่นน้ำสงกรานต์นะคะแล้วเราจะกลับมากันอีกทีนึงวันที่18 เมษายนนะคะในเรื่องของ fluoroscopy แล้วก็ในเรื่องของinterventional IRนะคะยังไงเดี๋ยวก็กลับมาเจอกันอีกทีนึงแล้วก็ระหว่างนี้นะคะหยุด2 อาทิตย์นะคะสามารถมาดูย้อนหลังได้นะคะมาเช็คที่แบบตอนฟังอาจจะฟังไม่ทันเก็บข้อมูลได้ไม่หมดมาฟังซ้ำอีกทีนึงได้นะคะทาง YouTube Channel Imaging Academic Outreach Center นะคะหรือว่าทาง Facebook Live ซึ่งสามารถมาดูย้อนหลังได้นะคะแล้วก็ขาดไม่ได้เลยก็ต้องขอบคุณสปอนเซอร์นะคะก็คือมิชชั่นนี้เราก็มีสปอนเซอร์มาซัพพอร์ตนะคะขอบคุณบริษัท Bayer นะคะ Philips แล้วก็ GE นะคะที่ช่วยมาสนับสนุนในเรื่องของการศึกษาของเรานะคะของทั้งรังสีแพทย์รังสีเทคนิคแล้วก็นักฟิสิกส์ของประเทศไทยนะคะที่มาช่วยร่วมในโครงการนี้ก็ขอบคุณทุกท่านมากๆค่ะขอบคุณค่ะอาจารย์ปาน Thank you so much Sam see you next 2 weeks bye bye
Thank you, Sam. Very happy to listening to your talks. Always.